Wednesday. It may be 60 degrees next Wednesday, but what I'm planning on doing is hopefully I can get through the respiratory unit today, using today and Monday morning.
So you're going to try to fly through?
No, I'm not flying through it. I don't fly through stuff.
Okay, good.
So we will have that, because I've really got a lot of time if I'll keep my mouth shut and stay focused. Well, open my mouth and speak, but speak what I need to be speaking. So anyway, if I do that, I'll be fine. Get through it today. Monday we'll have from 9:40 to 12. Tuesday will be the check-offs. And Wednesday, if it snows, then we will not feel like we're missing anything. So if we get through everything, then Wednesday, if it doesn't snow, that is going to be a study section. That is going to be a review session. That is going to be the time that, Ms. Walker, I didn't get this. Okay, let's go. So we'll have, I think it's 2 hours that day. If I don't get through everything, then I'll get through it, and then we'll have the remaining time to get through all the material. Because the material is not that much reading. I mean, you might say, oh my God, I really want to read. But the reading is very complex, and you know that we are a concept-based curriculum. So the concept of this, you know, you've had acid base and you've had fluid and electrolytes. You are now beginning to start the concept of disease processes. One of the biggest things that I can tell you if you're having trouble with the respiratory system and understanding anatomy and physiology of the respiratory system, you need to review that. I've given you a little bit of slides to go through a little bit of review, but you need to understand, because I'm not going to teach you anatomy and physiology of the respiratory system. Okay? You need to do that on your own. So, it is concept-based, so we are going to be talking about airflow problems. Okay, because what I want you to do, yes, we're going over a lot of disease processes, but every one of them have to do something with respiratory. When you are in a nursing situation and you have a client that is coming in who has respiratory system problems, the care of that patient is going to be the same, because you're not going to walk in here and go, oh, let me see, do you have chronic bronchitis or do you have emphysema? I am not worried about what's causing that problem right now. I am worried about the fact that my patient has an O2 stat of 76. I don't care if it's because of COPD. I don't care if it's because of emphysema. I don't care if it's because of pneumonia. I care that there's a problem, and I got to fix that problem. And that's what the concept-based curriculum is all about. Anybody that has a respiratory system problem are going to tell you, are going to exhibit the same signs and symptoms of having a respiratory issue. You're not going to be saying, you're not going to be diagnosing, are you? Because we assess and we try to plan interventions to fix whatever's going on. Now, it is nice to know what's going on with the disease process of COPD, because then that can assist you as you get your patient stabilized, and in what it will assist you in what you will be looking for as far as doctor's orders and other interventions that you need to be going through. Okay? So just wanted to, since this is the first real system that you've had, I just wanted to let you understand what is going on with this concept-based curriculum when it comes to disease processes. You know normal, now we're doing abnormal. Just wanted to let you know, when you look on my unit, I've given you the readings, thanks to somebody who texted me and said, Ms. Walker, you don't have any readings up there. I have a PowerPoint that is labeled PowerPoint for respiration, or respiratory. That is what we're going to start today. There is a separate PowerPoint for respiratory medications that are on there. And during the PowerPoint that we're starting today, with the different disease processes, I have listed the medications that are used. But when you start looking at about those medications, the classifications and all that good stuff, you can go to your other PowerPoint with the medications, and it gives you a more in-depth, like the action and the side effects and that kind of stuff. We're going over it, but I just want to like to do it separate so you can focus on actually the meds too. Then the respiratory treatment review, we're going to do that in just a few minutes. You see that I've got the lab assignments on there, when they are due, and it says I will not take the assignments after this time and date. So that means it has to be to me. Thank you for people who have already started sending it to me. Just email it to me. Email your answers to me. That is part of the lab component, so if you don't do it, you get an unsat and you don't progress in the program. So let's don't get into a situation like that, okay? I've also put a lot of little funny handouts for you. There's also one that's specific to pediatrics. Ooh, I gotta slide that down, don't I? And I did another thing for the IV for beginners that you can pull up. It was brought to my attention this morning that I had put some practice IV medication stuff under the lab part of it. They're a little bit more, there were some that the seniors had brought in last year and had given me, and they wanted me to put it up there for everybody else to see. I really didn't even think about that when I was looking at them. They're a little bit more intense than what I want you to worry about for this medication. They're a little bit more difficult. They're giving you more information than I want you to have to convert to at this point. So if you practiced those med calculations yesterday out of that one and it stumped you, don't stress out about it. Okay, because that is not, I'm not going to be giving you all those different things and expecting you to do drops per minute and convert it to milliliters per hour. I'm not giving you that. Okay, that is a little bit more advanced. I want you to get the basics before we jump off the boat. Okay, so I apologize if you had any confusion with that, but I'm sorry. Okay. All right. Now, any questions? Actually, I want to do. Let me do this first. I can figure out how to get where I need to go in the show. All right, I'm opening up the review of respiratory treatments, that little handout. Because what I have found is as I am talking about different treatments that are done for respiratory, I'm up here saying, yeah, you need to have your patient do an incentive spirometer. But what I'm seeing is, yeah, you have that on your plan of care, and yes, you're going to do it, but you don't know what the heck you're supposed to be telling your patient. So I want to go through some of the treatments that you do when you have a respiratory patient. And so when I'm talking about the different interventions, when it comes to these disease processes, you're going to know how. When I say incentive spirometer, you're going to know exactly what you need to do to teach that patient. I think one of the biggest things that I take for granted when it comes to you guys in respiratory issues is that you know how to put O2 on someone. As a CNA, you're supposed to know how to put O2 on someone. Does everybody know how to go and get the equipment that you need, the tubing, for a nasal cannula? Do you know you go to the clean utility room, grab the tubing, and it has two little prongs in it, right? Does everybody know how to do that? Do you know how to put it on your patient and connect it to the wall and know how to, if the physician says, I want 2 liters of O2, do you know how to turn that monitor up to 2 liters? Do you know the little balls there? And I know this is sounding elementary, but I have had students that come and say, I don't know how to even put a nasal cannula on somebody. I need to make sure that you know how to do that. Let's say you've got a patient whose respirations are 35, and that was your first assessment. What would be the next assessment? Check O2 sats. His O2 sats are 76. What are you going to do? You're going to know how to go get that oxygen, set it up, and put it on how many liters to start off? 2 liters. Okay? Now, one thing that I'm seeing that you're doing this, but you don't have an order for that.
In that situation, it's okay that you go get him one.
Exactly. In that situation, don't you dare sit there and walk out to the desk and say, just wanted to let you know that your patient's in room 4, his O2 sats are 76 and his respiration are 35. He's going to be a little bit angry. I'm going to be a little bit angry because I want you to do that and know how to do that without worrying about an order at that point. We'll get an order for it. Okay? You slap that O2 on that patient, 2 liters, and you keep that pulse ox on intermittently or continuous? Continuous. What's going to happen if it doesn't keep going up? Can I increase? How am I going to increase it? Pop it up to 10?
No.
I'm going to slowly increase that, right? Slowly. I may go up to 2.5. Then I'm going to wait and see what the respiration or what the O2 sats are. O2 sats not coming up. Where do I want to see those O2 sats?
90.
Greater than
92.
92. Now we're going to have lots of COPDers. Do you think it's going to be happening for them to go up to 92? We praise Jesus when it does, right? But where would I be happy with an O2 with a COPD? 90. I'll be happy with 90, so I can get them up to 90. Then I'm doing okay, but I really want to get people up to 92. Do you understand what it means to titrate people down off of oxygen? What did you just do? You gradually increased it. So the word titrate means I need to take it down because one of our goals is going to be for our patient to maintain their O2 sat. Help me. Maintain their O2 sats greater than 92% on room air. Did you just make a goal for a respiratory patient?
Yeah.
Yes, you did. If I'm going to see a nursing diagnosis in your plan of care for a respiratory patient, you're going to have that because that is your goal. Maintain O2 sats greater than 92% on room air. So if my patient's got 2 liters, and the doctor says titrate him because I'm trying to get him to go home, right? Do I want him to go home on oxygen?
No.
Do you know how difficult it is for patients to get oxygen at home? Would you think that would be something very simple for patients to get? You would think. But you know how hard it is? Do you know what you have to do for the patient in order to be discharged on oxygen? Do you know what you have to do for that patient have to do before they meet that criteria?
Insurance.
Go without it. Isn't that the craziest thing you ever heard? You know what we've got to do? We've got to take their oxygen off of them, and we got to walk them around the halls. And we're walking them, and what do you think their O2 sats are doing? They're dropping. Yeah. And you know how far they have to drop down before they qualify? 86. So what are we doing to our patients? You know, so it has you have the ability to have that resource for patients, but they have to meet the criteria before we get it. What if you have a patient that you know every time you've tried to titrate them down, they're dropping their sats? And you know that they're going to be getting ready to go home, and you know that you need to have that resource of having O2 with them at home. How are you going to handle that situation by taking the O2 off of them and having them walk?
Have it right beside of you.
Have what?
Have oxygen right beside of you.
Exactly. Do you think that's critical thinking? If I've got a patient that I've been trying to titrate down and he's not maintaining at 92, but yet I need to make sure that he's going to get oxygen when he goes home, I'm going to make sure I take that O2 tank with me as I start to walk him down the hall, and I'm going to slap it on him just as soon as he bottoms that O2 out. And I've got proof. Yes, he walked 10 steps. His O2 sats were 84. Is that my proof? Am I going to wait till I have to get him to walk back to his room and sit him down and put his... No, I'm going to take that O2, because if I let him go with O2 sats of 86, what is he not doing?
It's not perfusion.
Who said perfusion?
We all did.
Who said perfusion?
We all did. We all did.
Everybody said perfusion, right? So y'all know that's my word. If he's not perfusion, where is the O2 not going? To where? To my brain. So we're making our patients brain dead. Okay, because we're letting them go without the O2. I cannot stress to you enough about making sure that that patient's maintaining their O2 sats, because if they're maintaining their O2 sats, they're perfusing adequately, and they're not going to have damage done to their brain. So did we ever finish about titrating? I don't know if we finished about titrating. I told you I get sidetracked sometimes. So titrating it down, I got to pull it down. So if my patient's on 4 liters, what am I going to put it at first?
2 to 3.
No, 3. 3.5, 3. I can pop it down to 3 for a little bit. How long? What am I going to do at that time? That O2 sat's going to be on there the whole time, aren't I? Am I just going to have him sitting there? What can I do? Because I really want to know how he's reacting with activity, right? Because I'm not going to expect my patient to go home and sit in the recliner the whole time and his O2 sats are 92. I want him to get up and do something. So I need to have him not run 15 laps around the nurse's station, but get up, walk to the bathroom. Let me see what your O2 sats is doing when you're having activity. You've got a patient in the bed or whatever, can't get out of bed, then can you do some range of motion? Yeah, you do some range of motion with them so they're moving to see what happens. And then if it continues to stay up, how long are you going to wait? When I say maintain it, how long is maintain? I'm not going to wait an hour. About 20 to 30 minutes. Because that's going to give me an adequate account if he's able to truly maintain it by doing something, activity, moving, whatever. Is that maintaining? Not just sitting there doing nothing for 5 minutes and then I'm going to pop it right back down some more. So remember, what's our goal? To get him off of the O2. So you titrate it down and give him a chance to be able to compensate for the actual decrease of the O2. Everybody knows how to put a pulse ox on, correct? Okay. I know y'all think this is crazy, but... Alright, I've given you the examples of how O2 is delivered. You need to understand how it's delivered, there's several different ways that you can deliver O2. Nasal cannula, face mask, a partial rebreather, a non-rebreather, a Ventu mask, and a face tense. Those are the different things. I've given you the concentration of the O2 and what you generally will see as far as liters and O2 delivery of the different types. What do you think one of the biggest problems are with our mask? They don't fit. Are they comfortable for the patient? What does the patient feel like?
Suffocating.
They're suffocating, right? And they pull them off. So those are kind of things that we're going to have to take into consideration. And we'll talk about signs and symptoms in a minute of hypoxia. But we'll have to make sure that we get something that fits the patient and they can tolerate it well. One of the biggest problems that we have with patients who have nasal cannulas is it hurts their ears. Do you know that there's little ear pads that you can get from Respiratory to put on the tubing so it goes around their ears so it's not agitating to them? We may have to make some things to where it's not, when we put a mask on patients, that it's not uncomfortable for them, because that plastic putting right here is very uncomfortable. You can just go get a 2x2 gauze and stick that and double that gauze up and put it right here and see if it'll stay on the patient's face. It's very uncomfortable. But what happens a lot of times, if those masks are not on appropriately and doing what they need to do, like stay inflated with the non-rebreather, if it doesn't do that, if it deflates, what is going to happen with the patient? What types of things? Because remember, we've got, what did y'all just study? Acid base, right? If a patient has respiratory problems, what kind of
Acidosis.
acidosis, right? So they're in acidosis. What happens with acidosis? They have a buildup of CO2. So if those masks are not opening up like they need to, the little rebreather mask, what is going to happen to the patient? He's going to start retaining CO2. So you've got to make sure that you've got that mask on appropriately and make sure that it is opening like it needs to and closing like it needs to, because if you don't, you're going to have a problem with the CO2 buildup. And your patient's going to go in respiratory acidosis more. I mentioned the CPAP and the BiPAP. Those are also assistance that we give to our patients. Right now, you're going to study BiPAP and CPAP in your senior year more, but I wanted to introduce it to you so you would know. You may still have patients who have CPAPs and have BiPAPs. The CPAPs, remember, that is working to maintain the patient's airway on a continuous basis. Is continually doing it. When you have the BiPAP, it is more when the patient is taking inhalation in. So it's called a bi-level, so it's not continuously helping the patient. They're both still maintaining what? Maintaining their airway. Exactly. That is the whole purpose of having it. It's got it in the term, airway, because for some reason, that patient is not able to maintain their airway on their own. Who snores at night? You know why? Because my airway is not opening up. There's something, whether I've got a big old tongue, when I relax, it's coming back, and there's something not making, whether I'm sleeping like this, there's got to be a reason why my airway is not opening. That's one of the biggest things that happens with patients, or one of the biggest symptoms that happens with patients when they have to have a BiPAP or a CPAP is they snore. So that's going to be the major reason they go to the doctor and say, you know what, that's what my husband said to me. She snores. Fat. At first I thought, well, it's just because I'm fat. You know, I'm fat, I'm sorry. But then as I started looking at how I laid down at night and how I was all crunched up like this, no wonder I snore. Because my airway is being clogged up because of all the funky ways I sleep. So what's happening is I've got to get my patient's airway open. So when you lay down at night, you need to make sure that you're in line. Your body's in line so you don't shut that airway up. Is that a major thing that we do as nurses? Was the first thing we always make sure we do? Maintain that patient's airway. All right, another treatment that we're going to see is in-stem spirometer. This is one of the biggest things that I see that nobody knows how to teach the patient how to do an in-stem spirometer. This is an in-stem spirometer. What do most patients want to do as soon as they get it? They want to go like this, and then they look and say, my face go up. Is there a reason why? What is the purpose of this in-stem spirometer? Is it not inhaling? So everybody knows how to teach somebody how to use an in-stem spirometer. You're putting your mouth on here. I borrowed this from a patient on IP. I cleaned it up and all that kind of stuff. But, okay, so you've got to teach somebody how to do an in-stem spirometer. Yeah, you said that they're going to inhale with it. They need to know how to put their mouth on here. I'm not putting my mouth on here even though I cleaned it. They need to know how to put their mouth in here, and then they're inhaling. Let's set a goal for our patient. Remember, because we're goal-oriented nurses. Do you want your patient to go, okay, first day, 4,000, let's go. Come on, let's do it. Can you do 4,000? I can do 4,000. So I can't do that on the patient. How are you going to figure out a goal for me? Have them do it one time as you're teaching them how to do it, because the first time they do it, even though we're telling them to inhale, they're still not going to get it. It's almost like y'all sometimes. We have to take it over and over and over again for you to get something, and that's okay. That's how we learn. But it's going to take several times to get them to know to pull that little thing up. What do you think would be a good starting point for someone who has COPD or has emphysema or has any type of airflow problem? 500 to 1,000 would probably be good. So as I'm setting my goals, I'm going to let them try a couple times and see how they do at the beginning, and let's see what they can pull it up on without a lot of pressure. And then let's say, okay, so are we going to go from 500 to 2,000? No. We're going to take baby steps to get up there. Okay, so if we did it 5 times at 500, then the next time I may say, let's try 1,000. How often should you be doing this?
Every hour.
Every hour to 2 hours. Most physicians will write in-stem spirometer every 2 hours. How many times do you want them to do this?
10 times.
10 times every 2 hours. Does it mean that they have to 10 times just like that? No, what's going to happen? They're going to hyperventilate. Then we're going to be in another set of trouble. Okay? So, especially patients who are just well, let me ask you this question. What other patients? You know, respiratory patients, which is pneumonia and that kind. What other patients do I want to have this done? Surgery. We're going to go over OR. You're going to do this with your patients with surgery. Why? What is the purpose of this? I want to prevent pneumonia in a post-op patient, right? Because that's the #1 problem that we have with patients who have surgery. They get pneumonia. But I've already got pneumonia. So what is this doing for me?
Make you cough.
Huh?
It makes you cough.
It does make you cough, but is it expanding the lungs?
Yeah.
Okay, expanding the lungs. And what does coughing and turning and all that kind of good stuff happen? It makes you get that junk up. Because generally what's happened with pneumonia, what is it? We got junk in our lungs, right? That ain't supposed to be there, so there's got to get it out. I need you to do this as an intervention. This is a major, major intervention that I need to see you. I do not like to see these things in the bathroom of the patient's room. You know, I'm sure that is not going to do him one bit of good. The last time, I can't remember who it was. Liz, maybe. Your patient? Alicia, your patient. Tell them what happened when we went in there. She hadn't even been taught. What did she have, COPD? And she hadn't even been taught how to use the in-sim spirometer. She'd been there for how many days? 2 days. 2 days. COPD. No in-sim spirometer. It was in a room. So what did we do when we went in there? Because we know that's an intervention that I'm going to do with people who have respiratory problems, just like you are. What did we do? Yeah, she didn't know how to do it. At least she was honest with me. She didn't know how to do it. So who taught her? I taught her. What happened right after we did this one little set? Maybe three or four times.
I was scared because she started coughing everywhere, but you were all relaxed.
I don't usually get into panic. There's sometimes I get in panic. But what was this supposed to do for her? Make her cough. And then what'd she do? She coughed up a bunch of junk. Nasty looking snot that's been in her lungs for 2 days. Why are these people not doing this? I mean, geez. Are we doing this? Yes, we are.
Are those in the supply closet? Because I told it.
Yes.
I never saw anybody get them.
They are in the supply closet. And if you go into the supply closet and they're not there, you call in respiratory. Every patient that has a respiratory problem, every patient that has COPD, coming from surgery, whatever, I need to see this because it works. It works. Okay, I'm on my little wild page this morning. So everybody knows how to do that. All right, let's see what else. We've got percussion, vibration, and postural drainage. We are fortunate enough to have a fellow student that has respiratory problems. I don't know if you are aware of this, but Jade has cystic fibrosis. So she's going to come up and she's going to demonstrate some of the things that she does to help move those secretions. One of the
Don't be embarrassed.
Don't be embarrassed.
We're family here.
That's right. We're family. We're all learning how to do stuff. All right. One of the first things I'm going to talk about something with her, and I hope you don't mind me sharing.
No, it's fine.
Are you sure? Yeah.
She just heard it.
All right. With her cystic fibrosis, sometimes her lungs do not open up like they should. Right now, she's got a little bit of collapse lungs right in here, right into her bronchial things. So she's got to go back to the doctor tomorrow, and they're going to make her do much more intense types of treatment. One of the biggest things that we can do is called percussion. Okay, not the band that the thing. It's percussion. The bad thing about me as a nurse doing this is I feel like that I'm hurting my patient because I feel like I'm hitting them. And what happens with that? I do. That's the way I feel. When you percuss someone, you need to hold your hand in a cup, and you need to beat on their patient. And right here is where her lungs are not inflated right here. So if I'm going to percuss her right here, hoping that that's going to help her open that lung back up. She's used to this, aren't you? Yes. And you just move your hand around to help beat on that area. Now, so I sort of feel like I'm hurting my patient. The other thing that they have, and this is what I was telling Jade about this morning, is especially on pediatric patients, they have a little, it almost looks like a hammer. And it's like a suction. Has a little suction, and it has a little thing like this. I'm not good at describing. But it's like this. So it has this type of contour to it, and it has a handle. And you can just take it and beat with the handle, and it's more condensed to certain areas where I feel like my hand is pretty big and it's getting an area. I don't know that my hand is doing something if I've got widespread, but if I've got just a confined area right here, that's going to give us a smaller area to work with. Okay, so on pediatric patients, that's what you're going to see. Okay, you want to show them your vibration thing?
Sure. This is my vest, and this does the cupping so that my boyfriend doesn't have to beat me every day. But the tubes connect to the machine and into this. There is a vest, an actual vest, instead of this wrap. And I don't like it because it hurts.
It hurts, and we don't want hurt.
So you put it on.
Is it plugged in?
Yeah, it's plugged in. You turn it on.
Is it loud?
Well, the one we had for work is.
It fills up with air. My vest makes me feel like the kid off A Christmas Story. Thing. And it just does this.
Can y'all see?
And you can,
She can't talk while it's on.
no. But you can increase it and decrease it. I do this for 20 minutes, 4 times a day. And this sends a puff of air to stop it if you need to stop it real quick. And then it just pauses it and you just turn it back on.
Isn't that neat? That's like my Go-Go machine.
Shake the fat off of you.
You can see it shake the fat off of her. She has no fat on her, so it's obviously working. Can I borrow this one, Dave? Especially right here. So these are the types of things that we have for vibration. Cystic fibrosis is a disease that this is an awesome tool for it. We may not see a lot of vibration in the hospital like this unless patients have newly diagnosed with cystic fibrosis and we're bringing it in to help teach them how to use it. But I thought it was awesome when Jade asked if she could bring her stuff in. I thought, shoot, yeah, at least you can see what it's actually doing to the patient and see that she's very compliant. Did you hear her say, I do this 4 times a day for 20 minutes? So she's very, very compliant. All right, what else you got, girl? I don't want to make you come up here and be embarrassed any longer than you have to.
I'm okay now.
After you do it,
What now?
can you tell an obvious difference after you do it?
Usually after I do it, I start coughing a lot, and I cough a lot of stuff up.
So is it working? Mm-hmm. Yeah. Is that not the object of it, to get this to happen? All right, this is another device. This is called the flutter valve. Now, she's got a daggum fancy one. The ones that we have in the hospital are not this fancy. But if you'll show them how the flutter valve works, this thing's amazing. It really is amazing.
This thing on the end, it twists to give you more resistance if you want it. But you don't puff your cheeks, you just blow in it. And it vibrates your lungs. There's a ball in there that vibrates and that brings stuff up too. So I do this after that and after my breathing treatments. I do this after every time I do that. Too.
You blow a lot when you don't inhale.
Right. Inhale with the incentive spirometer, blow out. Now, if you don't mind, when you blow it, can you feel your vibrations in your...
Mm-hmm.
I want you will you let them feel just to see? Would that matter? I mean, so you can actually see that it is...
You want to feel?
Yeah, we don't want to wear you out.
I know.
You're fine, sweetheart.
But see, this is the intervention that's helping her. Right? Is that not cool? Love it. Yeah, I think she's got one of them that she says it makes her feel like. Yeah.
When it gets really bad,
And told me to suck it.
I get ill because my dad
Does it vibrate just right
he
here
doesn't
there?
have any of this stuff. He doesn't.
Right. He doesn't have it or is it?
I think my mom did say at one time he had an incentive spirometer shoving. She said he threw it away. But like last year he got really bad. Like he'll probably get bad when the weather changes like this. And he has spurts where he thinks it's pneumonia, but what it is, he still smokes.
Yeah.
He is trying to start smoking.
And I'm not going over because I've already told you that the process of respirations and the respiratory system, I am not teaching you that. So I have given you a outline of what happens with the transport of oxygen and carbon dioxide through diffusion. But I guess I can, yeah. The age, I'm not going to go over that. All right. When we talk about respiratory issues, you've got to think it is an airflow problem, right? It's airflow because the air going in and the air going out, that's where our problem comes in. So what I'm going to do right now is I want, for a minute, I want everyone to sit here and just breathe normal. Get through your nose. Breathe normal. Relax. All right, so start now. Anybody have any trouble? Anybody get short of breath? Yeah, everybody's breathing good because we don't have junk in our lungs, do we? Okay? We got to think of what it's going to feel like to have junk or not be able to get air in and air out like we want to. So I want you to get your straw, the big straw, the big straw.
Do this on Survivor. Barry, you need to be through a straw.
And for one, if anybody has asthma, you may not want to do this.
I know.
All right, we're going to put the straw in our mouth, and we are going to breathe only through this straw. Don't breathe through your nose. Only through this straw for 1 minute. Okay? Smokers, you might have a little trouble. Okay? All right, put it in your mouth and go. right, that was 1 minute. Who had difficulty?
Had a hell of an
How did you feel? Could you tell it was a difference in you getting air in? Big difference, wasn't it? Several of you had to push it and had lung problems. It hurts, doesn't it?
It started off quiet.
Right.
like any other muscle
Breathe. It was a little bit difficult. Think about our patients who have an airflow problem. They can't just pull the straw out of their mouth, can they? Did anybody feel a little anxious?
Yeah.
Just heart rate going up? So when you see your patient having an airflow problem, just in that 1 minute, you can see what you started feeling, but yet you were able to pull the straw out. And you were able to take that deep breath and get your heart rate back down and get a little bit more relaxed, because now we've got a normal airflow problem or airway issue, right? We're all having good with our airway, aren't we? We're getting that airflow in and the airflow out. That's probably the way some of our patients feel when they have respiratory issues. Now get your little coffee stir.
We breathe out through our nose. Can we breathe out through our nose?
Breathe out through your nose because you got a nose full of snot. So you can't breathe. All right, for the next act. I think I'm going to initiate some hypoxia going around here. Everybody know for the next hour. See, we're only doing this for a minute. Sorry, everybody failed out because Mrs. Walker had hypoxia and their brain dead. All right, get the straw. We're going to do the same thing. Obviously, I don't want anybody to go out on me, but. All right. All right, go. Bad? A little bit worse? How do you think our patients feel when they come in and they have an airflow problem and they're not able to get that air in like they need to and get that CO2 out? That is one of the scariest things, isn't it? Do you know what the number one, did anybody feel hypoxic? Sort of feel a little hypoxic. You know what the number one sign of hypoxia is? Say it loud. Restlessness. State Board of Nursing is going to want to know what the number one sign of hypoxia is. It's restless. Did any of you feel restless at that moment? Do you think you were the least little bit hypoxic? Maybe a little bit, but think about our patients that come in and their O2 sats are 76. Think about them. Think about what they're feeling right now. The first sign that you have got to pick up when a patient has any signs of decreased airflow in, they're going to become restless. What happens when you jump in a pool and you go to the bottom? Exactly. Do you not start fighting to get back up? Well, that's exactly what our patients do. They start fighting for breath. They become air hungry, just like we do in a pool, and we've got to get up as fast as we can. But yet when we come up and we take that deep breath, we're okay. Our patients aren't. And it's a constant thing. So we have to make sure that we not only just look at the physical things, we have to look at the emotional things, because I can tell you right off that if I can't breathe, I'm going to get scared and I'm going to get restless. And I may even be, have you ever seen anybody who is drowning and somebody's coming to save them?
They drown down.
And what do they immediately start doing? They start fighting. They start fighting because they're scared. And you will see patients that are hypoxic, scared, and begin to start pulling. The least little bit of might be the first signs of hypoxia that you have to pick up. That is what you've got to assess. You've got to make sure that you know that restlessness is a sign of the first of hypoxia. So as we're looking at alterations in the respiratory system, I can't say to you enough, we've got to maintain our airway. We have to. So you have got to see that that patient is able to move that air in and move that air out. Now, there are different types of obstructions that can happen with a patient. Different kind of sounds and stuff that they make to let me know that they're having an issue. One of the sounds I want to start off with, and I've got a YouTube thing, I'm hoping I can do this. I've never done this before, but I'm going to see if I can show you what stridor sounds like. This is a breath sound that's going to tell me that there is some type of occlusion going on with my patient. That's a siren, not a stridor. Okay, what do I need to do? What am I doing here?
Volume up.
Turn the volume on the wall.
Although nothing except its intensity distinguishes stridor from a monophonic wheeze to the ear, stridor is a particularly loud musical sound of constant pitch. Listen to this example of stridor in a child with croup. Although nothing except its intensity distinguishes stridor from a monophonic wheeze to the ear, stridor comes from obstruction of central airways such as the trachea or larynx. Wheezing is produced in more peripheral airways. Listen again to stridor.
Do you think that's going to be a good sound to hear? Not a good sound to hear. So when our patients, what are you thinking when you think about the respiratory system and how the air goes in and the air goes out? What do you think's happening with stridor? It's squeezing through, so everything's sort of narrowed down and constricting down. So is there a gas exchange happening?
No.
No. So no. Do we have an airway problem too?
Yeah.
We got an airway and a gas exchange, because what he said is it more up in the trachea area. So there's an airway issue, and there is also an issue with lower too. When you see, and these are I just gave you some definitions of the conditions that you're going to see that's going to affect our breathing patterns. When you're assessing a patient, and they're having an airflow problem, what do you think their respirations are going to be? They're going to be high, right? What's that term? Tachycardia. Exactly. So you need to know that. What is bradycardia? Slow. When do you think you're going to see that? Anesthesia might be something that causes slow respirations. Some medications, drug overdoses. No, asthma's going to make it go up. COPD is going to go up. What? Hang on. Respiratory acidosis will make it go
Up. Down.
down. No, respiratory acidosis goes up. Respiratory acidosis, I thought you said alkalosis. Alkalosis goes down. So you're going to have to be assessing to know what? One of the biggest things that you see patients have, Brady, is when they're getting ready to pass away. Okay? You will see the respirations go from 8 for a while, and they may be 4, and then they may be 8 again, and then they might be 4. So you're going to see Brady and down. Everybody knows what apnea is? Most patients who have, I know you've heard of this sleep apnea. So what's actually happening with sleep apnea? They actually stop breathing in their sleep. It's a very dangerous position because they're asleep and they're not aware of it. When we have periods of apnea, when we're awake, we're aware of it. And you're going to see that as patients begin to die, they will have respirations that they're going really, really fast, and then all of a sudden they have periods of apnea. Huh? Right. We're going to talk about that in a minute. But what other... Now, when I say apnea, don't we always think, oh my gosh, apnea. They're not breathing. What am I going to do? I got to do something. What other patients that we would take care of that would have periods of apnea that I wouldn't be major in a fit over? My newborns. Because think about their respiratory system. It is not mature yet. So they have periods that they'll go. You know what their respirations usually are? 30 to 60. Think it's going to be hard for you to count respirations on a newborn baby? Yes, it is. You have that hand on your chest, and you know what your hand... This is the way I check respirations. Been doing it for years and years and years on a newborn because it's so fast. I put my hand on their chest, and my head goes like that. Same thing with the heart rate. Heart rate's running up 160. Okay? So babies are going to have those periods of apnea. When would I be concerned? How long will I let that baby go with a period of apnea before I'm concerned?
A couple seconds.
15 to 20 seconds. So I wouldn't be... That went down the wrong way. I would be concerned, but I wouldn't be concerned if a newborn baby had a period of apnea that was 15 to 20 seconds. Because I know that that is a normal finding. I know that I may want to shake them a little bit, just not really shake, but hit the little bassinet or something to startle them so they'll start breathing again. It scares moms to death because they're sitting there, they don't understand about the anatomy of it, and they're sitting there. I mean, those of you that have babies, how many times did you go to the bassinet and look down there and go, no, they're not breathing? They're not breathing. Yeah. And you always go in there and you're like putting your hand on going, they're breathing.
A mirror to their mouth.
Yeah, it is scary, but we have to teach our moms and moms and dads that this is a period.
Mine's 12 and I still do that.
It may be a common sight. All right. You have hypoventilation and then you have hyperventilation when it comes to respirations. Smalls is another breathing pattern. Smalls that I found. I couldn't find a good one. I was a little bit aggravated that I couldn't get this one good. But this is another breathing pattern that you may hear.
Today we're going to show you how to set up your insulin pump.
No, we're not.
You were getting your car repaired, and you left the insulin in the car, so the car was in the shop, and so you were absolutely out of insulin. And so because you miss the insulin, then you develop the diabetic ketoacidosis.
Oh, sorry.
How do you feel, how does this present? How do you know that you're in diabetic ketoacidosis?
Is that better?
Shortness of breath. So I want to demonstrate for our viewers your breathing pattern. So this rapid breathing pattern that she's got going on here.
Try to count her recipes.
What's this called?
That's known as Kussmaul's breathing. It's a respiratory pattern where they take deep, inspiratory breaths and then attempt to blow off their carbon dioxide.
In response to their acidosis.
Yeah.
Can you smell ketones?
I can't smell ketones, and to be honest, I'm not very good with the fruity odor of ketones. I'm not.
And some people, there's a certain percentage of people that really can't smell the ketones that are associated with diabetic ketoacidosis.
That might be me.
You're one of them, proud?
All right, how do I get this down? All right, did you see a big difference in the rate and rhythm and the depth? You know, when we tell you to assess respirations, it's not just a number. It's how they're actually taking that deep breath. She was very deep. What is she trying to do? She's trying to get rid of that CO2 itching. And that's the only way that she knows how to get it is to make it be rapidly. So patients who have respiratory acidosis will have increased CO2 buildup, which may lead to metabolic acidosis. Okay, so she's trying to get rid of that so that we're all together and we can sort of know that our respiratory system can affect our metabolic system as well. Okay, I'm going to flip this light back on. All right, the other breath sound that I really wanted to find, and I could not find any that wasn't sort of just what was happening is the patients were dying. And I really didn't want to show that because when you see Shay Stokes, the patients are dying. Have you ever heard the death rattle? Okay. That is what Shay Stoking is. It almost like they have something right here in their throat that is gurgling. So it's like, just like that. It's not major airflow problem there. Major. So that is what you'll see with the different breath sounds with there is an airflow problem. Okay? All right. Am I going the wrong way? Okay, not going over that. All right, so if we have inadequate oxygen to support our metabolic system, what does that mean?
No tissue.
So if no oxygen's getting there, what do we have? Ineffective tissue perfusion. We are not perfusion because of our oxygen. So our patients are going to be hypoxic.
Early rats.
Huh?
But rats in bed.
Rats in the bed. Exactly. Early rat is late to bed. All right, so signs of hypoxia. Did you just see the number one sign of hypoxia in your eyes, in your body? Restlessness and anxiety. And if we become anxious and have anxiety, what is our heart rate going to do? Exactly what yours did. Okay? Now, if that's going to be an early sign, a sign that you've got to pick up when you have a patient who has early signs of hypoxia. You got to know that. If you don't pick up those early signs, eventually it's going to be a late sign because you have let your patient become more hypoxic. And as they become more hypoxic, you're then going to see their heart rate go down. They're going to be more short of breath. And they are going to be to the point where we were like coming out of the pool and we could not get up. And they're going to be so restless and so anxious. So anxious. Now, some of the other things, as we let this continue, I want you to understand that pediatric patients can't tolerate the least little bit of hypoxia. Like, sometimes we can compensate enough as an adult and being a healthy person if we have a little bit of hypoxia, just like you guys had a little bit a while ago. You were able to compensate and resume your normal breathing patterns just from that little bit of early signs of respiratory or hypoxia. With later signs, we may not be able to bounce back as much. Sometimes babies can't tell us, or pediatric patients can't tell us that we can see that they're having trouble breathing, but your facial expressions was telling me I'm having trouble here. Sometimes they can't. One of the first things that you'll see is when they start to become, yes, their respirations are going to be high. Their respirations sometimes are 30 to 60. We're talking 90. These babies' respirations are 90. That's a big, big jump. They're going to tell you, I can't, or they're going to not tell you, but they're not going to want to eat at all. Because if they eat, what does that do? It takes up all their energy to eat when they need all their energy to what? To breathe. So they may start showing that. Another thing that you're going to see is you may hear that stridor with them, with pediatric patients, on inspiration. But these are the three signs that you will see very, very commonly with pediatric patients. Their nares begin to flare. Do you know what I mean when I mean flaring nares? The nostrils, the nares start going like this. And what do you think they're doing? Are they having an airway problem? Or airflow problem? Yes. They cannot, they are trying to use every little muscle they've got in their nose to get the air in. So you're going to see some nasal flaring. The next thing that you're going to see is expiratory grunting. Do you know what I mean by grunting? Expiratory grunting. When you inhale, it's normal. But when they exhale, now, how many times have you heard a pediatric patient sort of sounds like they're whining, right? Mm-hmm. So what do you think you normally would do? It's going to be okay, right? And we're going to try to comfort them, correct? Not going to help. It's not going to help to try to comfort them because they're grunting because they're hypoxic. I'll tell you a story about me in nursing school. I was in the newborn nursery. I was just like y'all, green as can be, and I walked by the little basket. I mean, there's like, I was at CMC Maine, so you know they have the babies by the bundle. And there was probably 15 or 20 babies in there, and so I'm walking by there, and this one's going, I'm thinking, oh geez, do I keep walking, or I will keep walking? I know what to do here, you know. So anyway, I said, you know, you really need to go back here and check on it, baby. So he was still grunting, so I go over there, I was like, you're okay. And I'm like, okay, we're fine, you know. And I was like, oh Lord, I'm gonna walk away. And I thought, I just got to go back and check on that baby. So I went back, and he's still doing that funky noise. And so I sort of pulled the cover back, and I went, okay, my instructor told me that the baby was supposed to be pink. And if I saw any problems then, I might need, you know, other than pink, I might need to let somebody know. So I'm up here going, you know, somebody come help me. And I was like, I don't know what's wrong with this baby, but something's not right. And they were all going, oh my gosh, you know, that student nurse, she thinks she knows what she's talking about. You know, I was like, I really think somebody needs to come over here and look at this baby. So finally the nurse comes over there, and when she got to the baby, she pulled the covers back, and the next thing I knew, she had swooped that baby up, she had run that baby over to the stable, and here was every intern and everybody coming in that newborn nursery. I was going, I didn't do it! I promise. I was like, oh my God, what have I done to this baby? You know, I was like, geez, the ways. You would feel the same way. You know, oh shoot, fire, what did I do? So I'll sort of sit back there. And this nurse finally came over there. I mean, I had big tears in my eyes going, I don't know what I do. I'm going to get sent home. I'm going to get kicked out of the program. It doesn't matter that this baby is really sick over here. I'm worried about getting kicked out of the nursing program. So anyway, to make a long story short, when I get over there, the nurse finally came over and said, I'm so thankful that you stopped when that baby was grunting. I said, but I don't know what it means. I have no idea if I did anything. And she said, yeah, you did something, and you did something very good. And I was like, oh, Lord, this doesn't happen. People don't tell nursing students if they did something right. And come to find out, what had happened was that baby did not have a septum in the middle of its heart. A birth defect. But that baby was 24 hours old. Why didn't someone pick that up before a stupid nursing student saw it? That baby had been showing signs and signs and signs of grunting. He didn't just start grunting when I walked by. You know, he had been doing that for a long time. But luckily, that I walked by, didn't know what I was finding. I was able to take that baby down to the NICU. I mean, we shipped it down to the NICU. I was able to go get the parents, bring them down there, and we were able to hold that baby till he died. But I was very upset, cried, did the whole 9 watt, thought I had done something wrong. It was nothing I did. I just saw something that I didn't know what was wrong. But I can remember somewhere in my little brain that my instructor said that grunting noise is not right. And the color was not right. But I wish that someone would have found it earlier so those parents could have loved on that baby for a little bit longer. He had already been 24 hours old. That mom should have been holding that baby the whole entire time. But anyway, he died because he didn't have that septum. So the moral of the story is, when you hear anything, see anything in a nursing situation, and you're not sure what it is, please go get somebody. Hopefully it's not as drastic as my little situation was, but if you don't know what's causing it, let somebody know. Hey, is this normal? The other side, as I looked at the child and they laid the child out, I noticed that it looked like somebody was taking their hands and pushing down in their chest and then coming back up. And then putting down in the chest and coming back up. And I said to the nurse, I was like, why is he doing that? And she said, well, it's called retractions. Retractions of the actual chest wall as the patient is trying to pull as much oxygen as he can use. He's using everything in his body to try to get enough oxygen in and enough CO2 out to make gas exchange. So when babies are more common, older adults will do the retractions, but you'll see it more in patients, in pediatric patients. You need to look and see, are they digging deep here? Does it look like, and it's right through here, like it comes here and it sinks in here and comes out. So it looks like somebody's really just pushing their hand in your chest and retracting down. When you see retraction, that is not a good sign. That is never, ever a good sign. So when you're looking at your patients for hypoxia, if we don't catch it here, then we're going to see this with our pediatric patients. And we're going to see our patients, our adult patients, go into severe respiratory distress and have to need lots and lots of treatment. So the moral of the story is listen to what you're seeing at the beginning of your assessment. All right. There are several groups of air flow limitation. A lot of people have trouble. Okay, sorry.
I also see like in a toddler retractions up here, like in the throat and the neck, because my son was too. That's when they found he had asthma, but because I noticed it was really sinking in here when he would breathe. So is that also part of it?
You know what that's called? Use of accessory muscles. He was more or less using every bit of these muscles right here to help him get his air in and air out. Isn't that one of the things that you need to be assessing for when you go to respiratory? Not just pediatric patients. We, adults, do that. We use every muscle that we can use around here to help pull that O2 in. So yeah, it's very, very common for our patients to use all the accessory muscles. But if I wait to the point where it gets sunk in here, I know there's a problem. I mean, it is definitely, it no longer becomes just an airflow. I mean, it is an airflow problem, but we might now have an airway issue along with gas exchange as well. So the moral of the story is catch these people before they go into those situations. The bad thing is most patients won't come to us until they're in that situation, to where their O2 sats are 76, they're using their accessory muscles, their respirations are 40. They're not going to come to us because they're going to try to compensate themselves at home. My dad was the worst one. Don't take me to the hospital. Don't take me to the hospital. And they don't want to come. But I can tell you, with patients who have COPD, and that's what we're getting ready to talk about right now, when I say COPD, I mean a chronic problem. It continues to happen over and over and over again. Is a COPDer ever going to have full usage of his lungs? Never. So he's always going to have an airflow problem. But what we have to do is to help maintain these airway problems, this airflow problem with our COPDers. And hopefully I'll be able to show you ways that we can do this as we start studying this. Now, when you look at lung disease, there's 3 different processes that sort of encompass the COPD. Does it mean, well, let me just say that asthma, emphysema, and chronic bronchitis. Does it mean everybody that has asthma as a child is going to have COPD? No. Does it put them at risk? Yes, it does, because they've already had some issues. Hopefully, we were able to treat those issues to not cause any further damage. But when you're looking at these 3, and those are the 3 that the main ones that we're going to talk about, and we're going to talk about the different things that happen with each one of them. But as the patients come in, they start out with the chronic bronchitis. Chronic means it happens a bunch. Doesn't mean we have one episode of bronchitis. It means when the weather changes, we're going to see this patient come in and he's going to have bronchitis. And then a little bit later, feed him full of antibiotics and breathing treatments and all that kind of stuff. He may get a couple days of good airflow, but then it's going to happen again. And then as it continues to happen, eventually the patients are going to have emphysema. And as they have the emphysema and the changes that happen with that, as they see this patient over and over again, we're going to see it named chronic obstructive pulmonary disease. Okay, so I don't want you to sit here and say, okay, I'm just not getting that. It's just know that to get this disease process diagnosed, it's not a one-time go into the hospital and have a respiratory issue. It is someone that you see over and over and over again. The thing with asthma, and this is what you have to realize that is so important when it comes to an asthma patient. The patient, when it's an asthma problem, it is an airway problem. It is definitely an airway issue. We'll talk about the others later. But with asthma, what's happening is there is some type of obstruction in the airway that is either swelling up so the air cannot get in and out, or the top of the bronchial tree has begun to constrict. It's starting to clamp down. And so if that is happening, if that inflammation is happening in that airway, can I get airflow in? I cannot. If my bronchioles are constricting, I cannot get airflow. The good thing about asthma, if there is a good thing, it is reversible. Can we do something about the inflammation? We can give medication to assist us in decreasing that inflammation. Can we do something about bronchoconstriction? We can give medication that will assist in bronchodilation. Good. So that's going to be the problem that's helping. Is there a gas exchange problem? No, it is not. Why?
Obstruction of the airway.
Because it's the airway. Does it go down to the alveoli? No. So there's not infections or not infected by our gas exchange. Does that mean that every asthmatic patient that comes in is going to have a normal O2 sat? No, it does not mean that. So just because you know that it's an airway issue and it really hasn't gone to a gas exchange problem yet, they're still going to show you signs and symptoms of respiratory distress. They're still going to have the increased heart rate. They're still going to have breath sounds that are abnormal. What is the most common breath sound with the asthmatic patient? Wheezing. Do you know what wheezing sounds like? Sounds like a muzzle. When you blow up a balloon, I'm such a visual person, I hope you don't mind. When you blow up a balloon and then you squeeze it like this at the top and it makes a little sound like, that's what wheezing sounds like. Okay, so that gives you a better way of knowing. Has everybody heard wheezing? I need you to hear that. Of course, asthma is the leading cause of our chronic problems with our little patients, our babies. Hey, I just realized this works. Yeah, 30 minutes left in class. Leading cause of a chronic illness in our childhood. The one good thing about children who have asthma at an early age is, what do you think happens? They grow out of it. Exactly. So if there's anything reassuring that you can tell moms that come in with their babies that are asthmatic, that the good thing is that they will hopefully they will grow out of it. It's very common that they do. Okay, I'm going the wrong direction. All right, so what kind of things cause this problem, this asthmatic problem? Allergies is one of the biggest things that will cause an asthmatic attack. So if we come in contact with things that we're allergic to, that's going to stimulate a reaction where our body says, I don't like it. So what happens is it starts trying to protect itself, and when it protects itself, it starts swelling up and saying, you know what, you're not getting in here. I am taking care of myself, you're not getting in here. What do you think one of the worst things about allergies are? Besides asthma? Not a good question, right?
Sometimes you don't know what they are.
That's what I'm trying to get to. I'm glad you can read my mind. What I'm trying to get you to say, which it wasn't working too good. The bad thing about allergen is sometimes we don't know what we're allergic to. So we may be around Jennifer and she's got Louis Vuitton cologne on, and I come up and get right beside her and I start sneezing and my nose starts running and then I start getting short of breath and all that kind of, and I start having wheezing. Then I would either think I'm allergic to Jennifer or I'm allergic to her cologne. So you may not ever know sometimes what you're allergic to. Now obviously, like with my brother, he's severely allergic to cats. When he gets even anywhere near a cat, he starts. So what do? Stay away from cats. So we've got to get them away from that problem. that is going to cause the allergen. Yes, testing to see what you're allergic to is very common. You will see that if the patient comes in and they're having an asthmatic attack, there will be several questions that the nurse asks the parent or asks the child. Have you changed anything? One of the first things we ask is, have you changed your laundry detergent? You know, have you changed soaps? Have you changed anything that you're in contact with every day? So it's like a guessing game to figure out what we're allergic to, unless we put our patients through a severe testing of allergies, or to see what they're allergic to. I have an allergy to the ingredient that makes shampoo lather. Isn't that crazy? Of all things to be allergic to, I'm allergic to cocoa, morel pill, betaine. Now I had to go through all kinds of tests, and I had 72 little sticks in the back of my back to figure out what I'm allergic to. So, which is crazy. But you have to do that so I'll know. I don't use any shampoos that have that in it. And I'm cured. I don't have any problems. So that's what we got to do with patients that have the allergies that they're allergic to. Sometimes it seems to happen more with cold air. When the weather changes, people have a tendency to have more asthmatic attacks. Any kind of airborne particles, microorganisms, and asthma. ASA is aspirin. You know you don't ever give aspirin to a pediatric patient. No. You know that? Okay. So sometimes moms may not know that, and they've given their pediatric patient some aspirin. Now they're saying that NSAIDs is also going to cause some allergic reactions. So that may be something that you see later on, because this is just a new thing. All right. So here's my little, wait a minute, I want my, where's my asthma atom?
Yeah, I think you just don't have asthma.
I don't like this thing.
Down one more.
All right, so what, of course I've given you lots of little funny things like this. The things that trigger it, we've talked about that. Another thing that may trigger asthma attacks is exercise. One of the things you want to teach someone who has had asthma and they want to exercise, that it is good to use their inhaler prior to, if they're going to exercise. What type of bronchodilator, exactly. Because if I'm going to exercise and I know that it gets me short of breath and I know it may trigger, that's why I don't exercise, trigger an asthma attack, then it would be good to get 2 puffs in prior to doing that activity, so my bronchioles are opened up and are able to pull that O2 in and get those CO2 out. My son had an asthma attack playing indoor soccer one time, and I have never seen a child go as quickly as running down the court to lifeless on the side. Did I medicate him prior to? Yes, I did. It's not always going to work, but it's going to help. It's going to help. So just, teach moms, if they're going to exercise or they're going to be activity, please, especially anything indoors, basketball, anything like that, that closed in place makes patients not be able to breathe as good.
I didn't know, but I've never had asthma.
Mm-hmm.
I have had an asthma attack. Mm-hmm. And
right.
They said that it was a sports-induced attack.
Exactly.
When I ran cross country.
Exactly. Middle school?
High school.
High school, yeah. And that's very, very common. It just happened to be the conditions. That was it cold outside or was it warm?
It was probably
yeah. Cold air. Trigger never had a problem before, and then him doing exercise and in that cold air, you inhaled something that your body didn't like, and it immediately told you. So, do you have an inhaler, or was it just an isolated case?
They gave me one.
Yeah. All right, so, and the reason why I was talking about, or I'm glad that you brought up that, it's more common in males. And it usually happens, you know, either the guys are, and I don't know if it's because they're more active and doing sports and stuff, I don't know. But, I mean, I was pretty active too. I played softball, I played basketball from the time I was walking. I mean, I was majorette. I was pretty active too. I didn't never have any problems. But it does occur more in males, and it's usually, if they're going to have problems their whole life, it's going to happen after they're 12. Now, usually when they have it young, they're going to grow out of it. But if they start developing asthma problems after they're 12 years old, it's probably going to be a lifelong thing that they're going to have to deal with. You're going to see tachycardia, restlessness, they're going to have a cough, shortness of breath, wheezing, all those things that we talked about. One of the I do want to show you what, and I think all of you have seen that, but I thought it was pretty neat how you can see the bronchioles are bronchial, not alveoli, right? Because asthma is not going down to the alveoli, right? Not going down there. So I thought it was really neat that you could actually see all of the mucus and everything in there. That's just a visual for you. All right, where is my asthma? Oh, there he is. All right. I just love my little asthma Adam. Is he not the cutest thing? The cutest thing. Okay, signs and symptoms that you're going to see with a patient who has, and we've already talked about every one of those. Audible wheezing, increased rate, respiratory rate, coughing, use of accessory muscles, retractions, and tachycardia. So those are the kinds of things that you're going to see. What is going to help you tell the difference? Well, no, I don't want to do that yet. I don't want to do that yet. All right. As the patient's, this is one disease process that, as you see it progress, doesn't, well, I'm not saying that good. I'm trying to think of what I want to say. All right, what I want to say is one of the signs and symptoms that you see with asthma is wheezing. We know, we've established that, right? Whether it's wheezing that you can hear with a stethoscope, or is it just wheezing that you can hear when you walk into the patient's room and you don't even need a stethoscope. The badness of the wheezing is not a way that you can tell how bad this attack is. That's what I'm trying to say. Most of the time, if you have breath sounds that are getting worse and they're traveling all over the lobes, you would think that the patient is really, really getting bad. But when I start out with wheezing, and my patient comes in and wheezing, and then I listen and there's no wheezing, what would I think first?
Better.
Oh, he's getting better. Not with asthma. Because you can get to where your breath sounds went from wheezing to diminished, and the obstruction mucus that's in there and the inflammation in there is more and worse. So you can't tell the severity of an asthma attack just on your assessment of the wheezing. Okay? You can't base it on just your assessment of the wheezing, because if we had wheezing to begin with, wheezing's telling me what?
You're still moving.
There's movement there, isn't it?
So if the wheezing starts to go away and you haven't done anything, that's bad.
Right. So if we had wheezing to begin with, am I reassured? I'm reassured to this point that at least there's something trying to exchange, right? It may not be coming out full force, but at least it's getting in and getting out okay. But then now I don't have wheezing. Then I got a problem. The severity of my patient is getting worse. Does that make sense? Sometimes I have trouble saying stuff. Kind of things that you're going to be testing for is you're going to see ABGs done. You've already went through ABGs. You know what ABGs are, right? How do you think that little child's going to react to having ABGs drawn? Not going to be happy. Do you know where they take the sample? The artery, not the vein. Do you know where they stick? It's right here. They usually stick right here. Respiratory comes in. Your patient has had ABGs drawn. What is a nursing intervention that you need to do after your patient has had an ABG drawn? Pressure. You better hold pressure for how many minutes?
5.
At least 5. But what is our patient at risk for? Exactly. Because what did I just strike? An artery. Okay, so that, I don't mean just go in here and go, oh yeah, I'm going to put a little pressure right here. I mean pressure. And the respiratory therapist may not stay that long. You might have to make sure. Or if she says, I did an ABG on your patient in room 4, I put pressure for 5 minutes, he's still bleeding, you better go in there and you better make sure that you put more pressure and take care of that bleeding, because I do not want him to hemorrhage. Alright, I'm not going to go into pulmonary function test yet. I think we're at a point where we can stop. Before we know that we've got a airflow problem, right? And we're not going to diagnose if it's asthma, emphysema. We're going to look at what's going on. My mother-in-law's sats were 85 on Saturday. What would you do if you had a patient in the hospital whose sats were 85? Get their head up. I can go ahead and put O2 on her, and I'm going to put her O2 on her at 2 liters. I'm going to get that. Yeah, we ain't going to worry about orders right now. We'll get it one way. We're going to check that pulse ox, right? Again, after the oxygen's been on, we're going to make sure that 2 liters is working. Do you think 2 liters is going to pull 85 up?
No.
Don't pull it up. Okay? You're going to have to get it increasing, but you're going to continually monitor that pulse ox to see what it is and what it's doing, because my goal is to get it where? Greater than 92. Right. Well, y'all did learn something this week. Last week. I'm proud. Woohoo. Asthma is probably one of the biggest things that I'm probably going to test on, because I know you want to know what's on the test. Because asthma is so common. We see asthma every day. And so I want you to be familiar with the signs and symptoms that you're going to see with asthma. Now, I just said, Miss, don't worry if it's asthma or whatever. It's a respiratory issue. But asthma is one of the biggest things that you're going to see most commonly. One of the biggest ways that we can evaluate or help our patients with asthma is what? What is our major goal?
Airway.
Clearing our airway. But let me say, maybe not in an acute setting.
Yeah.
It is prevention, isn't it? It is health promotion. It is a way that I've got to help this person after they're in an acute situation, to help manage them when they go home. I.e., let's make sure we know what type of things that trigger it. Are they allergic to something? Stay away from it. what caused them? We've got to investigate. Sometimes I think I'm an investigator. I really do, because I've got to figure out the questions that I ask. Sometimes I feel like my patients are on trial. Because, what do? We walk in and we've got a list of questions. And we start asking. Sometimes they just don't understand, why are we asking them so many questions? And I need to ask questions because I need to know what's causing this. Why did he have this asthma episode? And that way, if we figure out what caused it, then we can encourage him not to be around that again, or not to do this. So that's one of the biggest things that you're going to see when it comes to asthma. One of the ways that they are treating or assisting in the health promotion and management of a patient who has asthma or any lung disorder is the pulmonary function test. It is a combination of different tests that you'll see the patient doing. And you can see a list of them. Most of the physicians are going to use the abbreviations. So I encourage you to know forced vital capacity. They're not going to say that whole term out for you. They're going to say FVCs. So we'll know. What does that mean? An FVC is the volume of air exhaled from a full inhalation. So if you think about it, what do I want? How do I help my patient do that? There is an incentive spirometer, or it's like, not really an incentive spirometer, it looks like incentive spirometer. There is a picture on one that you can, a portable one, that asthma patients can take home with them in your book. And I think I put the page number somewhere for you to look at. Somewhere, I don't know. But it's in your book and it has a little flow meter. It's got a flow meter. And that is something that does the same thing as a pulmonary function test does when my patient's at home. Now, I need to do one in a controlled environment in the hospital. So I need to go, my patient needs to do that whole set of pulmonary function tests. Then when he goes home, he's going to be measuring his pulmonary function at home as well. And you'll see what I mean when I'm talking about he'll do it at home, because it's going to give us an indication of how is he doing. Okay? So let's focus on these here. So my patient's going to take a big old inhalation, right? And he's going to force exhalation. So that little machine, when they put that little machine in his mouth, they're going to instruct him how to inhale and exhale. And this little machine measures, has its measurements. Do I want you to memorize what the measurements are? No. Whose job is that? Respiratory therapist. Okay? I just want you to know the different types of things that the testing they go through. Now this is unlike lab values. Okay? I want you to know the ranges for lab values, right? Mm-hmm. But for this, I don't want you to worry about memorizing what type of numbers I'm looking for during these tests. Okay? The forced expiratory volume, that's when I really want my patients to blow. Forcefully blow out so I can look and see, because what this term says is exactly what they're doing. It is a forced expiratory volume. So as they do what? Exhale. Once they exhale with everything that they've got, that machine's going to monitor it again. Okay? Forced expiratory volume is exactly what's measured. How much of the volume do they have when they take that deep breath and then they force everything out? This is a little bit hard for people who are in acute situation. Very, very difficult. So do you think that the numbers are going to change? But I've got to see what these ranges are, what these numbers are when my patient's in an acute situation. Right? Because I know if it's in an acute situation, I'm going to know how to what? Treat it. You just told me what happened when a patient has a decreased O2 sat. Did you not tell me things that you were going to do? The same thing happens with this. When we have a variation in each of these areas, while my patient's in an acute situation, that is going to assist the physician on how he's going to treat it. He's going to have information to let me know, does this person have an inspiratory problem, or does he have an expiratory problem? Isn't the treatment going to be different? What types of patients are we getting ready to talk about that has an expiratory problem? COPD. What expiratory problem do they have? They can't get rid of CO2. So in planning my care of this patient, am I going to focus my interventions on inhalation? No. So now let's think through this just a minute. If I have a patient who has COPD, and I know that it's an expiratory problem, meaning that I can't get rid of CO2, what type of problems, well, let me just say, what kind of interventions are not going to help a COPDer that you do for most everybody that has respiratory or airflow problems? What is the first thing we want to give them? O2. Is that going to help? No. Who is that going to help?
Inhalation. Your inhalation problem.
It's going to help my inhalation paper, but who really is it going to help? Me, because nurses need to do what? We need to do something. No, we got to do something for this patient. But I have to understand the pathophysiology of the disease process and know that the COPD is an expiratory problem. That's what's wrong with it. So me giving him O2, it may help, but do you think it's going to correct? Is it going to make it worse? Is it going to make it worse? Because the more oxygen we give them, right, the only way that keeps our little drive to breathe. And then, as we give more oxygen, they're going to start hanging on to CO2. And then they're going to do what? Forget to breathe. And that is not our goal with a patient of COPD. So, when we're talking about pulmonary function test, I do not want you to get caught up on the values. I think I've said that. But I do want you to understand which each one of these tests do, and to know that we need to test these in an acute situation. What do you expect the volumes to be? Messed up, don't you? But isn't this going to give me a better idea to see, is the problem inspiratory or is it expiratory? Yes.
Are they all, if somebody has them, they're grouped together, so you always give all three together?
Yeah. Actually, there are a few more that are involved with that too. But these three are the ones that you really see the most common I was going to try to see if I could.
We do them in our office, and the nurses will tell the patients to breathe normal for the first time, and then to take a deep breath and then blow out. So is that the second part, the FEV they're doing? If they're taking a deep breath and just blowing as hard as
Right. It'll be the expiratory, because they're blowing out as hard as they can. Okay? So we have to, I don't want you to get so caught up on how to measure, because as a nurse, what I would do when I was looking at in a chart, and my patient had pulmonary function test. You know when you look at your labs and it tells you, here's the normal range, here's my patient, there's a big old asterisk beside it that says this is wrong, or this is abnormal, or high or low. That's exactly what we as nurses do. We pull that pulmonary function test, and it tells us this patient's numbers are this, but this is the reason why. So I'm going to be looking at that reason why that things are going. I'm not going to be focused on the numbers. Okay? So when you look at these now, you're going to see, obviously, a decrease with patients who have asthma. Because is that, where is the problem with asthma? Right in here. So is it affecting the volume of getting in and out?
Yeah.
Because my airway is the problem. So with asthma, you're going to see those numbers be low. Age has a little bit to do with it, but not as much. They do look at that, but there again, that's the physician. He's going to be looking at that to tell me. Educate. We know educate. What I really want you to see is this right here. Y'all can read all my little things. With this peak flow meter, say my patient's been in the hospital and he had bad pulmonary function tests. They were very, very below what we wanted to see it for this type of patient. We have intervened, we have educated, we have given medicine, we have done all this stuff. So we're going to not just, do you think that the problem, first of all, is going to be corrected right then? No. It may take a little bit of time to get this corrected. Can I keep the patient in the hospital? Yes, I can, if he's having severe respiratory problems. But the majority of the time, what happens during their acute phase, we get them out of a dangerous status, and that we send them home. But the thing of it is some of these interventions may not work with the activities that the patient does at home. Because most of the time in the hospital, what's the most activity we can do? Go to the bathroom or walk the hall. But then we send this little patient who has asthma, who was in an acute situation. I've got him stabilized. I've sent him home in his normal environment. He'll have his regimen of how he does medicine. He does his medicines, inhaler and stuff. But he's going to have this little flow meter at home. And what he's going to do, before he leaves the hospital, we're going to give him a log of when we want him to do this. In other words, we want to see what your volumes are first thing in the morning. And then he'll document it. And then they may say, we need you to do this type of activity. And I need you to do the flow monitor. And I need you to mark your scores or see what your numbers are. And then we may say, we want you to do the last, they'll give you different times on when we want you to do it. And what that flow meter does, it gives us a percentage of if we are doing this correctly with his regimen. I want to see that he's in the green zone. So when he does that flow meter, it's going to tell him either red, green, or yellow, just like a stoplight. And you can always remember when it's green, that's what we want, because we want to go. Because if it's green on his flow meter, on these different things, what is that telling me? The interventions that the physician has ordered for him and the medication that has ordered for him, along with his activity of daily living, is working. So this means my patient's in good control of what's going on. So now let's say our patient's been in good control for 3 or 4 days, but he's still doing his log. Well, he decides that he wants to love on his grandma's cat. Ooh. We weren't sure if he was allergic to cats or not, but when he goes over to his grandma's and he's playing with the cat, he starts showing me signs and symptoms of some respiratory problems. At that point in time, what do you think he needs to do? He needs to do his flow meter, and he needs to see, where am I? Where am I here? Oh my goodness, I might be in my yellow zone. And what do you think the physicians have given him if he ends up in the yellow zone? They have given him instructions on what he needs to do if he ends up in the yellow zone. In other words, if it's yellow, you need to do this and then this. Then, what will we do again? Check again. And once we check, what are we wanting to see? Green. It goes back to green. What if he's in yellow again? It ain't working, is it? Is this not what we do every day with patients? Yeah. Every day we are doing this. We are trying to find interventions that work for our patients. This is an excellent tool that we have. A lot of times they may go in yellow and they have a regimen to do, just like when we're in the hospital when our patients have a problem with potassium. No, let's go blood sugar. Because there's a list that says, if it's this, this is what you need to do. If it's this, this is what you need to do. That's exactly what happens with our patients with the flow meter. What do you think is going to happen if my patient's in red? I got to go to the hospital. Because probably what has happened is he started out good in green, got into that trigger, made him go to yellow, did what they told him to do in the yellow, and the yellow interventions didn't work. So now, isn't this a good tool to have? Because they know when they need to go get help. They can use that flow meter and it'll tell them, we have done all that we can do, you've got to go get assistance. Okay? So this is a very vital tool for you to use for patients who have any type of respiratory issues. When you are looking at this, you look at it just like any other intervention. Because green means go, and green means I'm doing what I need to do. Yellow means I need to do something else, to change something, and red means you go get some help. Okay? And you can look at the different percentages there that will tell you which one will help. Medication administration is probably one of the best interventions I can do for a patient who has asthma. There, as you saw on your medication PowerPoint, I gave you many meds that use the term rescue. Did I not use rescue? For a patient who needs rescue, our teaching about this med is vital because they may be given 3 different inhalers. They may be given, they will be given a controlled medication and a rescue medication. My controlled medication is something that needs to be what? Done every day, religiously, just like someone who has hypertension. They take a beta blocker every day. Same thing with respiratory patients, not just asthmatics. My emphysema patients, my chronic bronchitis patients, my patients who have COPD. They're going to be on inhalers just like they're on every other med to be given. It has to be used every day. What do you think one of the biggest teaching things that you need to do for a patient when they have several medications that are used for asthma? Which order I give it in, and which one do I need to use in case of an emergency? And sometimes what I used to do is I would have my patients, especially my little pediatric patients, get a little piece of paper and write in red, like something like emergency or help. Something on there that would identify that inhaler, because what if these kids have to take 3 inhalers with them everywhere they go, or have something? When they grab and they're really struggling to breathe, and I come up and I'm like, can I help you? Can I help you? And he's pointing to his book bag. And if I pull out 3 inhalers, if I've got one that's marked red, help, is that not going to be a good sign for me to grab that and then get it in him? Okay, so you've got, that is one of the biggest things that you, and I'm hearing everybody getting the concept already of that bronchodilator. If you had a choice on when you're even not in an acute situation, but in an everyday thing, what are you going to teach your patient about the order that you're going to give that medication? You're always going to give a bronchodilator first, based on the understanding that we know the
Airway.
What's that?
Airway.
Action of what a bronchodilator does. Don't we need to know the action of that? Is there a reason why I asked y'all, what is the action of this drug? So you'll know it's going to open up. It's going to open up and let everything else go in. You will see, here is the types of drugs that I have listed. I have also put them on another PowerPoint for you as far as their action, their uses, and all that kind of good stuff. But so I'm not going through every one. Is everybody understanding that the bronchodilators, there's sub-categories? There's 4 subcategories under my bronchodilators, correct? They're all bronchodilators, but they all do different things in the bronchial system. They're going to have, in other words, they may do, one may work better for a bronchospasm. One may be that it just gets down into the bronchioles, not everywhere else. So all of these are bronchodilators, but they all have a little bit something different. Okay? And then the anti-inflammatories, I've listed those. The most common ones that I want you to know is your short-acting and your long-acting beta agonist and corticosteroids. You're going to see those so much. Now, can anybody we talked about some of the drugs the other day. Can you remember some of the things that we will see with a patient who's given a short-acting bronchodilator? What kind of signs and symptoms are they going to show you? They're going to be nervous, and their heart rate's going to be racing. So you need to know that. Other things that you need to know about one of the biggest, and I really didn't mean to get onto the meds right now, but I feel like I probably need to say this several times. Corticosteroids. You are going to see steroids given for patients who have respiratory problems. Because what does corticosteroids do? They decrease inflammation. What has been, look at the pathophysiology with asthma, emphysema, COPD. What's happening in that airway area? Inflammation. So this is going to help decrease inflammation. So you're not just going to see one drug given for patients who have asthma, COPD. You're going to see combinations. What is the biggest side effect that you're going to see of a patient who's had a steroid? Blood sugar. Exactly. So I can tell you right now, if you ever give a steroid, you better be checking the blood sugar. What are you going to see in patients who, like what type of number do you think I'm looking for when I'm talking about, oh, it's going to shoot the blood sugar up? How much? 300, 400. Yeah. We're not talking 121. Okay, I'm talking 3, 4, 500. 500. Now, what's going to happen with that patient with a blood sugar of 500? He's not only going to have signs and symptoms of the steroid going on, he's going to start being shaky, nervous, diaphoretic. Okay, that's going to be, so that may be one of the first things that you see in a patient. He's not going to go in there. He's never been a diabetic. He don't know what's going on with a blood sugar problem. If he's had anything like normal people, not that people that don't have COPD are not normal, with normal people, when it comes to blood sugar, if you're not a diabetic, do you know that your blood sugar's high? No. You'd know when it's low, don't you? That may be a symptom. You may know. I have no idea what high blood sugar. As much chocolate as I eat, my blood sugar probably sometimes is 5,000. But I don't know if there's any difference. I'll just go along with my little happy self. But I do know that it's low. So the patients may not realize that they, as a result of the drug that I'm giving him, that he's going to have issues with blood sugar. So what do you think I need to do to begin with? I need to be teaching him, don't I? I need to teach him, look, with this drug, it's a bad side effect. And what's happening is it makes your blood sugar go up. And when I need you, if you start feeling like this, to tell me, what do you think, so I can do something about it, what do you think you see that's ordered for a patient who's on a steroid and they're not a diabetic? Yeah, insulin, but it's called something else. Huh?
Metformin?
No, it's insulin. But I'm not diabetic. Don't be giving me no insulin. Will you speak up with your little self over here? Come on. Sliding scale. Sliding scale. Have you ever heard of the sliding scale? Have you ever seen the orders? F, B, FS. Okay, I can't do it that way. AC and HS. Have you ever seen that order? Do you know what it means?
before and after meals.
Finger, stick, blood sugar before meals and at bedtime. But I'm not a diabetic. Doesn't matter because I've been given what? I've been given a steroid. And it's going to make my blood sugar. So what? You don't think we teach in nursing? Can you see? If I go into the hospital, you give me a steroid, and I know nothing about you sticking my finger for anything. Right? I have a breathing problem. What are you sticking my finger for? Okay, and that's what our patients are doing. They don't understand. And then once we do that blood sugar and we see that it's 500, then what do? Oh my gosh! Miss Walker! I come in with a syringe and say, I'm going to give you some insulin. And they're like, but I'm not a diabetic. Is there any teaching that needs to go? It needs teaching.
You should probably teach them before he's ready to take it.
Exactly. Probably be a good idea to maybe, because you know when we walk in with needles, people don't, what's going on? So you've got to tell them, these are the things that you're going to be looking for. This is what I'm going to have to do. I'm going to have to check your blood sugar. And if it's between numbers, and you don't have to go down and give him the whole sliding scale and write it all down for him. You can just tell, I'm going to be looking at not the numbers. And when it's in between those numbers, then I'm going to have to give you so much. Okay? Do they have to be on insulin all the time? No. Is that not something you need to reassure them for? Please don't let me be on insulin all the time. It's just because you're being on a steroid. Okay, so hopefully once we get you off this steroid, we can get you off. Other signs and symptoms that you're going to see with a patient who's given IV steroid. Do you know the name of the drug that is the IV steroid that you going to give your patient all the time? Solumedrol. I need you to know that drug. Not just for this test. I don't even know if I put solumedrol on this test. But I'm going to tell you, you're going to give solumedrol, and it's going to come in a crazy concentration. So you're going to have to do a calculation. It can come in 80 milligrams. It can come in 125 milligrams. And your patient may get 40. Okay, so you're going to be doing a calculation when it comes to IV solumedrol. Tell me a side effect that you see with solumedrol besides increased glucose. Weight gain. Weight gain. We will have our patients look like they're 8 months pregnant within minutes. It is like, whoop. So now I've got a respiratory problem. Let's think this through. I've got a respiratory problem. Steroids going to help with my inflammation, but now I've got a lot of extra fat, fluid here, and it's going to make it difficult for me to breathe because what is it going to press on? My diaphragm. And it's going to make it more difficult for patients to breathe when they have that large abdomen. What kind of things can you teach somebody to breathe better? Sit up. Why do you think I tell you to put them up straight? I need them to be sitting up. Okay? Because I want all this to be stressed out so they got as much room as they can. It also impedes what of the lungs? Expansion. Expansion of it, doesn't it? So they can't do adequate inhalation. Interventions. What kind of interventions do we do for our respiratory patients? Deep breathing. Can they breathe deep if their lungs are not expanding like they need to? No. You've got to teach. Good. Another side effect I'm going to tell you about, and then I'm going to get going. Moon face. You ever heard the moon face? Yeah. Let me just tell you something, children. state board of nursing is going to ask you if there's a side effect of a steroid, and moon face is what they want to know. They'll ask you about hyperglycemia, but they're going to want you to know moon face. And I'm talking moon. I think I've told y'all, as soon as my daddy got Solumedrol, they gave my daddy 125 at a time. It's a very high dose. Yeah, very high dose. End-stage COPDers, you're going to see that 125. Not going to see it at the beginning. Moon face immediately. Abdominal out here. Okay, immediately. So you've got to do a lot, because patients will get up to the bathroom when they finally get up, and they'll go to the bathroom and they'll look in the mirror and they'll go, "What is wrong with my face?" Well, that's just a side effect of the medication. And some of the medication makes your little face just look like a moon. So you need to make sure that you're going to tell them all about side effects. I didn't mean to get on that. All right, we've talked about O2 therapy. Now, I put on that sheet about oxygen. What I want you to focus on when it comes to oxygen therapy, I want you to know that there's different ways that you can administer it. Respiratory therapists help us make the decision. But if let me get your thoughts on it. You've got a patient who is on, because the first thing we're going to put them on is a what? Nasal cannula, right? How high can I go up on a nasal cannula? 6 is about as high as I want to go for it to do any good for my patient. So if I get up and I've got a patient on 6 liters, not a COPD, 6 liters, how am I going to make the decision on what do I need to get next? Do I need to change the way I'm administering my oxygen? It depends on he's on 6 liters. His O2 sats are 86. Yeah. Do you know which one you're going to pick? Miss Walker! The most of the time you're going to pick a non-rebreather. That is the one that we talked about the other day that has the little bag here that I told you it can't do what? Be deflated, because it's not doing what it needs to do, and the patient's going to start doing what? Holding on to that CO2. So we're going to be in trouble. But when you have that situation, I don't expect you to know at this point in your program to know if my patient is declining on the way we're administering O2 with the nasal cannula. You know that you're going to have to do some other way of administering a higher dosage of that O2. I want to see you thinking it that way, and then we can say, okay, can a non-rebreather work for this patient? Because that would be my first thought process. But I have to look at all the other problems that are going on with my patient. Okay? Like an ABG. So I may have to look at everything. But I want you to, your thought process at this time to say, the 6 liters ain't working. I need another route that I can give this oxygen in. I want to try a non-rebreather. And then when you talk to your instructor, they'll decide, maybe not, maybe so. And it may be to the point, because I can tell you guys, there are people that went from nasal cannula to ventilator. Okay? So that's why I'm saying you may not have that assessment skill yet. And I don't want you to get fixated on the fact that Miss Walker says from nasal cannula, it goes straight to non-rebreather. Okay? Because it doesn't sometimes. It may be something else that I need, I'm sorry, he's on 6 liters per nasal cannula and his O2 sats are 50. We are not going to a non-rebreather. Okay? So there's a situation that you've got to look at your patient and see what's going on before you make that decision. Okay? All right. There is something very, very critical that can happen with a patient who has asthma. We generally do not see this. In fact, I have never, in the 25 years of nursing, ever seen a status like this. Patients are educated better now with asthma, and they're able to maintain it there. And you know, one of the major reasons why is we have what to give them? Those flow meters. Because they can tell when they're getting in trouble with the flow meter and go get help before they get to this state. This is a major emergency. This is when the patient cannot come out of that asthma attack. We have tried to give them every bronchodilator we can think of. We have tried to give them every inhaler, every treatment we have had, and they cannot come out of it. This is a very serious situation, and the patient will eventually, if they come in this type of situation, will be on a ventilator. Those are the ones that will come in and their O2 sats are 50. And we'll have to get them on a ventilator to get their breathing bad. This is not talked about much in your book at all, but in every nursing NCLEX book I have went through in all the years, they always talk about it. Always talk about it. So, and it may be they're a little bit old, but they always talk about this. And then one of the biggest things, because remember we talked about signs and symptoms of patients who had asthma and then they had wheezing, and then all of a sudden the wheezing stopped. Is that good or bad? It's not good, is it? So we're never going to look at the intensity of the wheezing to evaluate how our patients are, right? Because once we hear wheezing, we want to keep hearing wheezing. But once they start, that's going to be or stop wheezing, that's going to be one of the first signs that you pick up on to help prevent this patient from going into this asthmaticus. So you have got to be assessing those breath sounds when that patient's wheezing to make sure if they go down, there's a great possibility that they're going to, or if they go absent, there's a great possibility that that patient's then going to become cyanotic, then become more hypoxic, and once they do that, in order for me to help get that better, I'm going to have to put that patient on a ventilator because he's going to be so sick that he cannot breathe by himself. Okay, so it's very, very, I can't stress to you enough, when you've got an asthma patient, this is one time in your life when you're assessing an asthmatic patient that you want to hear wheezing. We want to hear that because that's, even though it's not good, it's telling me what? There's some exchange happening, right? But if it's gone, there's no exchange and that patient's going to get sicker. I've just given y'all my little management here. I will talk to you about Theophylline right quick, because if I don't get through all the med ones, then at least we've talked about some of the major ones. Theophylline. Theophylline is a drug that is not so commonly seen now because it has so many bad side effects. With our research, we have gone away from Theophylline because of the side effects. But your patients that are older, say 70 to 80, those are the ones that you're going to see on Theophylline. Okay? Because they were given Theophylline a long time ago, and that's just not a drug that you can take off. And just wean, you have to wean these people off. And generally, when patients have been on Theophylline, nothing else has worked. They have tried the steroids. They have tried anti-inflammatories. They have tried bronchodilators. And it's not working. So they have been on Theophylline, and it works for them. The bad thing about Theophylline is that patients can come toxic on it very quickly. That is a drug that they have to monitor their labs on a regular basis. If they do not check, and the normal range for a Theophylline level is 10 to 20. You need to know that Theophylline level, and you need to know that if a patient's on that drug, you need to know what that level is. Preferably before you administer it. Because the side effects are so bad with Theophylline that you kill people from, if they become toxic on it, you can kill them. And one of the first signs that you see when a patient is on Theophylline and is beginning to show signs of toxicity is increased restlessness. I'm not talking just a little agitated. I'm talking fighting. They are not fighting you, but fighting to breathe. They are fighting hard to breathe. So you need to know with a patient who's on Theophylline, you need to know what that level is, and you need to make sure that you have monitored that and knowing that the toxicity can occur, and your eyes and your ears and your nose and your mouth needs to be open to doing it, because people die from Theophylline toxicity lots of times. So I need you to be aware of that. I need you to understand that it happens, and that's why we don't like that drug as much. It can work, but it just has so many bad side effects.
Ms. Walker, what's some of the long-term effects of Theophylline when you take it for a couple of years?
Long-term depend a bit, or I don't like to use the word addicted, but patients have a tendency to really panic if they don't have it. So in withdrawing off of it, you cannot withdraw of it. So long term, I don't know, I really know exactly what it would cause.
When it's in the small children, can it cause problems later, with like learning or emotional or?
No, what usually, I think I know where you're going with this. What usually happens if we give Theophylline or aminophylline to a pediatric patient, the medication is not what's caused, if there's any learning disability prior, it's the hypoxia that occurred prior to the administration is what's caused some of the problems. Does that make sense? But I'll research that and see if it does cause long-term learning disabilities. But everything I've read, it's the hypoxia from prior to us giving them that med. Does that make sense? I do know I've got that mask O2, and I think this little funny thing was meant more for pediatric patients, because you have to think about a pediatric patient. Are they going to keep that nasal cannula in? No. So we have to make it fun and make them feel like they're a alien or an animal or something. I know when we gave Dylan his breathing treatments when he was young, they were dinosaurs. So he was like, "You can be a dinosaur. Can I be a dinosaur?" Yeah, you can be a dinosaur. Put the mask on and breathe. Please. I think I have went through a lot of the nursing diagnoses. I think y'all have heard me say the interventions that I am so caught up on. All right, y'all ready to take a break? Yes. All right. We're going to go look more at a chronic situation, which is chronic bronchitis, emphysema, and COPD. The things that is different from the asthma is that with asthma, it's airway issue, and it is easily reversed. When you have emphysema, chronic bronchitis, COPD, when the patients are having an exacerbation, meaning that they're in an acute situation, the tissue that is suffering from the hypoxia begins to die. It is not regenerated. So as these patients progress, we can have a bronchitis in an acute situation and then just have one here and there. But as it becomes to be chronic, that's when you're going to see the tissue damage that will eventually be emphysema, will eventually be COPD. So it's like an umbrella, so there's different things. Although the same types of problems are occurring within the lung tissue, the degree of the damage occurs as the disease progresses. So in other words, I have chronic bronchitis. I'm in and out of the hospital. I may not have that much damage on the 4 times that I've been there. But then that 5th time is going to then probably start causing more damage to where it looks more like emphysema. And then as they have separate occasions or problems with emphysema, as they come into the hospital, they're going to be called chronic obstructive pulmonary disease. And when you are chronic, when you're a COPD, you start having every time you have an exacerbation, every time that starts happening, every time you have impaired gas exchange, every time you have hypoxia happening, some of that tissue is dying, and it will not be able to regenerate. Okay, so it's not ever going to get better. And I think that's what I just went through with the difference in asthma and emphysema. Tissue damage not reversible, increases in severity, leads to respiratory failure, and it is reversed. So when we look at the pathophysiology of it, with emphysema, and that's the one we'll go over first, is there's actual destruction of the alveoli, and the destruction is not because of mucus, it's because of the inflammation that happens. Think about a balloon, and when we fill it with water, and we keep filling it because it's inflaming, because that's what happened with inflammation, right? It gets bigger and bigger and bigger. And as it gets bigger, the elasticity of it is not there, is it? So it's not going to be able to get the O2 in and the O2 out because there's so much edema. Now, the walls of the alveoli with the edema will become thick, not thin like a balloon. With the inflammation, it becomes very thick because they're little tiny grapes. The alveoli look like little tiny grapes, and they have a very thick. So as the inflammation, it's become thicker and thicker and thicker and thicker, and it doesn't expand. So when that O2 is coming in, trying to get in, it's like it's beating its head up against this wall and saying, I can't get in. And then, if it does get in,
Can't go back out.
What you think's gonna get it? It's trapped. Exactly. Once it gets in, I mean, you just want to tell it sometimes don't try there, go somewhere else. Because there is eventually some little alveoli somewhere that doesn't have that inflammation there. Go to another one. You know, go somewhere else, you little oxygen cell. But it doesn't know that. So as that, and then once that, it just swells, and then eventually it's just going to collapse. And as it collapses, it is it is dead tissue. It cannot perform anything. And once that tissue is dead, it will always be dead. It will not regenerate itself. So that's what happens with our patients who have emphysema. I put this little picture up here for you to look at. You can see that with emphysema, all that thickness of them, and they don't have the different little grapes, do they? No. They sort of just inflame, and they sort of all just mush together. So they're not able to do the job that they need to do. And you can actually see the emphysema in the lung to the left. And notice that it's not just in one place. It is in several different places. Do you see all the different areas of the emphysema in this patient's lung? So if you think about it, it's probably got more alveoli that are dead than are alive. There's so many different patches, and that's what causes our problems to have, our patients to have ineffective airway clearance. What is the cause? All you people out there on the road? This is what causes it. Smoking. The other thing that you see is, and this is what we see around Kannapolis because we're a meal town. So many people that we see in the hospital, in both of these hospitals, have worked. Our older patients have worked in the mill. And they have been exposed to asbestos. And as they become exposed to asbestos, they were beginning to develop emphysema, COPD, and also lung cancer. So, in majority of the patients that we take care of, those older men, they did smoke. But that may not be the only cause with them working in the mill, and we're sitting on a piece of land that the mill used to build. Hopefully they've gotten rid of all the asbestos, so we don't have to worry about that. And so be bothered by that. They also say that air pollution can cause it too. I don't know that I've ever seen a patient that has been diagnosed with emphysema just because of air pollution. I think it's other combinations. Now, your patients who have emphysema, what type of patients do you think that they are? Older, right? Older, because our lungs are pretty tough, aren't they? And just smoking a couple cigarettes here and there, you know, along the years, you know, you just keep building and building, you know, and as the years get on, it begins to do damage. Like my daddy smoked 52 years. And so eventually, you know, those alveoli are saying, you know what, I don't like you anymore. I don't like you putting this stuff in my body. I'm just not going to work anymore. And they'll die out. So our patients are really going to be the older adults who smoke for a long period of time. Sometimes, very, very rarely, you're going to see a young adult, meaning my age, or maybe y'all's age, come in with COPD. You just don't see it. If that patient, if a younger person comes in, it is and has been diagnosed with COPD, it is not because they've been smoking. It's because they have a genetic problem that is called alpha-1 antitrypsin. That is the only reason a young adult should ever have any type of COPD. The bad thing is do we know to test for this? No. When would we start figuring that out? Once they start having problems, and they're like, well, you don't smoke. You know, you didn't work in the mill. You're only 25 years old. What's going on here? Why are you? And they're doing the chest x-ray. And the chest x-ray is saying indicative for COPD. That is when that's the bad thing about it, is that we have no idea they have it until they've actually had some damage done. So if you see a young person, that is the reason why they would have had emphysema. I keep repeating myself up here. I just said that. All right. I was really amazed the other day when I was looking at one of the NCLEX books. Is I wasn't sure that NCLEX used the term pink puffer. And I saw it in there. I was like, oh, good. Because that's how I tell my students to tell the difference between emphysema and bronchitis is by the pink puffer. And I just call the little pink panther, too, because I love this little panther. I just think he's so cute. But these are just the clinical signs that you're going to see with a patient who has emphysema. They don't begin to have the increased retention of CO2 at the beginning. Because remember, there's inflammation there, and they can still get in, the O2 can get out, in, and CO2 get out. So with a patient who has emphysema, and this would be another way they can make the diagnosis, is with a patient who has emphysema, what do you think his blood gases are going to look like? They're going to be normal. But he's still having respiratory problems. But it hasn't got to the effect, or hasn't done enough damage yet to cause a gas exchange problem. So he's still pink. Because if he's perfusing, he is pink. After 4 hours of my mother-in-law, Shay Stoken, last night, her extremities are still pink. Someone please explain that to me. I have no idea why that lady is still got adequate tissue perfusion. She don't have any output, but she's got adequate tissue perfusion. And I can't explain it. But my little emphysema patient, he's still got it going on. He's still got that exchange of O2. He may show some signs of cyanosis, but it's easily repaired. If I give him a little O2, he's going to pink right up. Right up. Just a little bit of O2 will help that. He will do some type of pursed, and I don't know if I've even told you about pursed lips breathing. We talked about that. Patients who have, look at his little, and I need you to teach patients how to breathe pursed lips. It's like you're kissing someone. That's why I used to tell my daddy, please kiss me and blow out. You know, so you breathe in through your nose, and when you go out, you want to act like you're puckering. Not a big forced. It's just, that gives a little bit of push to help get that CO2 out. So they don't have problems with retaining. They do have some dyspnea. Not as bad as cough. They may cough a little bit, but it's not like our chronic COPDers and our bronchitis. That's when you're going to see the major coughing, when you get the bronchitis. Barrel chest. Have you ever seen anybody with a barrel chest? It really looks like a barrel. It looks like the patient's chest wall is way up here. It's amazing. We had a patient last year in the OR. He was laying in the bed, and when I went to turn and look, I thought, oh my gosh, that is the biggest barrel chest man I had ever seen in my entire life. I had to go get every one of the students to bring them in there so they could actually see a barrel chest. It's like here, and you actually sometimes can see where the chest wall comes up here, and you can see where their ribs are right here. It's really crazy looking. It's just like a little rounded thing. It's crazy. So their barrel chest, one of the biggest things is that is difference between this and chronic bronchitis is these patients are very thin. They don't get a lot, their nutrition is not as good. So they're going to be thin looking. They're also going to, and I think I've talked to you about respiratory verbalization before, is patients who have airflow problems have a tendency to not be able to speak in a long sentence. And remember, I think I told you when we were doing concept maps that is part of your assessment. With any patient who has respiratory problems, you want to see how many words they can say without stopping to get a deep breath. When our emphysema patients can go about 6 to 7 words without stopping to take a deep breath. When you see the disease progress, my COPDers, you're lucky if you can get 2 to 3 words out of them before they stop to take a deep breath. You may not think that's a very vital assessment, but it is major assessment, because when you have a patient who can't get but 2 words out when they're talking to you, you know you got a problem. You know you got a problem. Tell me an intervention you're going to do to help that patient.
Try to get them to speak more words.
Okay. Exactly. All right. No more words. Now, my goal would be if they were just speaking 2 words without taking a deep breath, my goal might be to speak 4, not 25. Don't go from 2 to 25 in 2 days. Okay? But maybe 4. But what we need to do to them, because what are they doing as they're talking? They're not having good gas exchange. So you know what I usually say? You don't have to talk right now. I need you to save your energy to speak. Okay? But I will ask you questions, and we'll have some type of hand gesture, like thumbs up for yes, thumbs down for no. So I'm going to change my communication with him. I'm not going to say, tell me about your whole life story in 15 words or less. Okay? That is not what I'm going to say to him. I'm going to say, are you hurting? Thumbs up or thumbs down? Rate your pain. 1 to 5, thumbs up. 5 to 10, thumbs down. I don't have to have an exact number. I got a gauge, right? Okay, or you can say, rate, it's an 8. Give me the hand. Listen to me. Give me something I can ask him yes or no. This is one time in your therapeutic communication that I want you to say yes or no questions. Okay? Because I don't want that patient every time he is speaking, he is using his gas exchange and he is using his energy that he needs to do what? To breathe. Okay? So don't be asking him to give you a dissertation about his life. Okay? We need short, yes, no questions. This is just a little picture that I found that this is so typical of a pink puffer. Once you see them, they're sunken in. which makes it very, very easy to assess the use of accessory muscles when they're breathing. This will make it also easy to assess retractions. Can you remember what retractions are? Okay, where the sternum goes in. All right, bronchitis. Moving right along. With emphysema, there was inflammation as well, right? There is also inflammation with our chronic bronchitis. Bronchitis is more of an airway issue. Asthma, bronchitis. Emphysema, COPD. Okay? So when you've got a bronchitis issue, you know there is lots and lots and lots of mucus. So what would be something that I need to know, or I need to be making sure my patient does if I know there's a bunch of junk in those lungs? I need to cough. And I need it to be what? Productive. I need it to be productive. I need to see lots and lots and lots of turning, deep breathing, and coughing exercises because I need to get it up. What if you can't get it up? Well, that sounds real good. Okay, get your brains out of this. You'll have reproductive in the summer. If he cannot get rid of the sputum that is in his lungs, what kind of things do you need to do? Turn, cough, deep breathe, and what's another?
Sound on the back.
Percussion, posture, flutter valve. Drain. I gotta hydrate him. Because what's going to do that mucus, that hydration? It's going to thin it out. Isn't it a whole lot easier to get out if it's thin? You got to be able, so you got to hydrate these patients as well. I did show you another little thing about what normal bronchi look like and the chronic, where you can see all the good and nasty mucus that Miss Walker does not like, that I cleaned out of my mother-in-law's throat all night last night. All right, what's our problems? Smoking. People at the road. Occupational substances and air pollution is also something that's listed, but I'm just not too sure about that one. But are we seeing a trend here? Yes. When it comes to respiratory issues, what is the major cause? So if you have a patient who has emphysema and has bronchitis and COPD, what would be a major thing I'd want to teach him? Stop smoking. Right. Is that really easy? Easy is a good one. No. So, guys, this is a very sensitive subject with people. It's an addiction. It's just like I'm addicted to my Lexapro. I gotta have my Lexapro. If I don't have my Lexapro, I can't function. Okay? So if anybody's talking to me about getting rid of my Lexapro, I'm gonna be fighting it. Okay? And some patients get like that. You need to make sure that we do small steps with them. There are not many patients who have smoked for 52 years, like my daddy, can stop cold turkey. When my daddy went in for his open heart surgery, he stopped and he didn't pick up another one. There's so many patients that cannot do that. We have got to work with them. We have got to give them options about, do we need to increase it? How many cigarettes do you smoke a day? 40? Okay. So if you do 40, can we try to do 20? Try to meet them a goal that they're going to meet. Don't just come in. It's very difficult. There's meds out now that can help patients that they may not be aware of. So try to work with them and see what kind of things could happen, or it could make him better, or to make it better for him, not just cold turkey. All right, our patients with chronic bronchitis, they are the blue bloaters. And what happens with my little bloater is he's blue. Is that a good color? Mm-hmm. That is not a good color. Although I do like blue, I hate Carolina blue. So, you know, although I take care of a lot of patients who are Carolina blue a lot of times. And one thing that happens with these patients is it is hypoxia definitely happening, right? But it's happening because of what? The inflammation and the mucus. So if I can get the mucus and the inflammation down, is my blue bloater going to be pink? He might be pinker, right? Blue patients who have chronic bronchitis don't walk around blue all the time. Is that what you are thinking? No. Okay, just let you know that they don't walk around. They, you know, when they're sick, they come in and that's what they look like. Because there's definitely a problem with the gas exchange. These patients are becoming hypoxic and they're also hanging on to CO2. So what type of acid base are they in? Respiratory acidosis, exactly. Increased respiratory rate. One of the things that is so common with patients that have chronic bronchitis and COPD in a late sign of COPDers and chronic bronchitis is digital clubbing. There's a picture in your book that shows you of what clubbing looks like. There's a little, with their finger there, it's like a little hump on top of it. When you do your assessment, especially if you have someone who has a history of COPD, look at their fingers. If they're beginning to club, like that picture, that means that they've had this disease process going on for a long period of time. It's a very late sign that you're going to see. The other bad thing that happens with chronic bronchitis is as we're trying to get all this mucus and all this junk out of our lungs, who's the lungs' best friend? The heart. The heart. Well, the heart says, oh, buddy, I'm going to try to help you. You're struggling a little bit. I'm going to start helping you out. So the heart starts getting involved and trying to help to push that stuff out. And then what happens is a disease process called cor pulmonary. It's the same thing as right-sided heart failure. When the heart starts picking up to try to help these lungs, the right side of the heart begins to pump quicker and not effectively. And so we start having a backup of fluid that's in the right side of the heart, and you're going to start seeing the cor pulmonary happen with that. At this point in your life, as a nursing student, the only way that you can diagnose that is by having a EKG, and you do not know how to run EKGs. So what would you start looking for in a patient who has chronic bronchitis that might be going in to right-sided heart failure? Dysrhythmias that you what?
You can only see on one side.
That you hear or feel. So you're going to know, what does it mean to have a dysrhythmia? It's an irregular heart rate. It means that the rate's not going at a regular time. It's irregular. So that may be the first sign that you hear or feel when a patient who has getting ready to go into right-sided failure, is that you're going to hear or feel their abnormal or irregular heart rate. What would you do if you had a patient who had an irregular heart rate? They come in, the heart rate's regular, everything's good. Now they've got bronchitis and we've treated them a day or two and they're not getting any better or seeming to get worse. And then you go to listen to their heart or feel their pulse and you notice an irregularity there. What is your first intervention? Miss Mother! First intervention, what do you want to have done?
EKG.
Exactly. Because how can I or help get arrhythmia, dysrhythmia or arrhythmia diagnosed? I never want to hear somebody put their stethoscope on their chest and say, oh, he's an AFib. You got a better stethoscope than mine because I cannot diagnose an arrhythmia or dysrhythmia with me listening. I have got to, so that will be something, I need an EKG on him. I need to get this in here and I need to get the physician to read that EKG and know what's going on with my patient. But one of the biggest things that you're going to hear or feel is going to be your irregular heart rate. All right. I just told you that. Y'all don't even need me. I mean, my goodness. The PowerPoints are pretty much spelled right out there for y'all. All right, assessment. We know, we talked about that. I will speak to activity intolerance for a moment. Now that I'm sitting here thinking about it. Most of the time when patients have emphysema or COPD, their shortness of breath is not only going to occur when they are doing something. It occurs as they're sitting there at rest. So notice that when you're doing your assessment, there are times that I want you to assess how patients tolerate activity, i.e., if I need to know if they need oxygen at home, where we got them up and walked them. I needed to see activity. With a patient who has emphysema or COPD, there are times that he can be sitting there or she can be sitting there and be so short of breath and has been sitting in that same chair for 3 hours. That is when you know that the disease process is getting worse and that we're going to have to intervene a little bit because what we're doing is not working. The patient should not have dyspnea at rest. And that's going to warrant us to do some type, another intervention, whether it's increase the O2, I don't know. We'll have to look and see what's going to work, but it's not working. You don't want to see dyspnea at rest. Very important. Another thing that you're going to see with that little emphysema patients, and I don't know, let me just ask you, when you're doing your assessment of a patient whose respirations, are you looking at their chest, the rise and the fall? Are you looking to see if there is a abnormality in the rise and fall or the side that it's coming up and down? So you do that for an assessment of that? Do you?
Yep.
Really? Seriously? I'm proud of you if you do. I really am proud. Because there's sometimes that I don't do that. Now, being on IP, I'm more aware of it. But if I have someone who doesn't have respiratory, I think what I'm trying to say, if I have somebody who doesn't have respiratory issues, I'm probably not going to look to see if it's symmetrical. to be honest with you. I am very proud of y'all do that. Y'all should do that. I should probably do that. But I think because I have so many COPD patients, then I'm used to looking. You will see with COPDers, you may see a difference in the symmetrical of the chest wall. You may see one going up and not at the same time. So that is something that you may see, you may not. We've talked about the digital. I talked about all that. I think I have probably just about knocked y'all out with ABGs, right? Okay, not going to talk about ABGs, and we know what's going on. Sputum samples. Do you know how to get a sputum sample from your patient? When is the best time to do it?
Early in the morning.
First thing in the morning. Do you know exactly how to get the patient to cough up, to put it in a container, and sit it down like it needs to be sit down? Do you not know how to do that? I don't expect you to, because you probably haven't gotten one, right? That is something when you get to clinical, you need to ask your instructor, can you please show me where the sputum sample container is? Now, when we get a patient who has needs a sputum culture or a sputum sample, I need that patient to get up as much as he can, but it's not always possible. So they need to do some deep, deep breathing, and they need to do some major, major coughing for us to get enough sample to send down. So when you're in clinical, I want you to go to your instructor and say, please show me where the container is to get a sputum sample and tell me how I'm supposed to get it. Okay? Because this hospital has a different one from this hospital. It's the same principle. It's a little orangey looking container, and it has a little tube in the middle of it, and you just pop the top off of it, and when they get the specimen up, you have them spit it in the cup. Okay? Yes, it is wonderful to do it prior to or first thing in the morning, because that's going to give us the best idea of what's going on, because that junk's been sitting there throughout the night. But that's not always possible depending on when our patient comes in. Because most of the time when our patient comes in with chronic bronchitis or any type of respiratory problem, and I want to sputum, what kind of treatments besides respiratory treatment do you think they're going to get? An antibiotic. So I've got a culture that has to be done on that sputum. When I get and I've got an antibiotic order. So I'm going to go straight in there and start that antibiotic and go.
No.
You put in the sample
Antibiotic, get the
first
sample.
to find out what kind of bacteria it is.
Exactly. Where have y'all heard that before? That is the point I'm trying to get across. Get the sample first. Then start the IV. Is it the same, or start the antibiotic? Is it the same thing with blood cultures? Same thing with blood culture. You know that sputum sample is the same as when we get a blood culture, is I need that done prior to making sure that I have a sample before I start the antibiotics, and you know why. All right, pulmonary function. Nursing diagnosis. Okay, I did say this. Maintain airway. And then right underneath it I said, airway maintenance is the most important focus of intervention. Yes, I did repeat that. I think y'all have got that more than anything. With a COPDer, we talked about oxygen. You're never going to give him more than what? 4 liters. A patient who has COPD, you are never going to give him more than 4 liters unless it's an acute situation and he's not responding to the treatment. Okay, so in other words, these patients need to know when they go home they don't need to get more than 4 liters. If they're still having trouble breathing, I can give him more in an acute situation to help maintain him, but he cannot stay on a high dosage of O2 for a long period of time. Because what's going to happen is that he's going to build up the CO2, and most of the times when we can't get patients, we have to start going higher than 4. Where do you think they're headed?
Ventilator.
Heaven or ventilator? Okay, that is what's getting ready to happen. Okay, what's the bad thing about being a COPD or being on a ventilator? You can't get them off of it. They're very, very hard to get them off the ventilator because they become so dependent so quickly. So our goal is to not have to put a COPDer in that situation. That's why you will see lots and lots of COPD patients having a no-code status, meaning DNR. They know, they have been taught that if I go on the ventilator, I probably will not ever come off. So they don't want to put, because where does the bad part go if I've got a COPDer that doesn't have anything written in his will or living will? And we put him on the ventilator? Who has to suffer? The family, because the family's now going to have to make a decision to turn the machine off. So education is vital with my chronic patients. Talk to them. The physician will talk to them about, are you having a hard time talking to somebody with a DNR? I mean, about having a DNR status? Are you? No? Hard, isn't it? Be honest. It's hard for me. I've done it for how many years? It's hard for me to talk to somebody. But I need to know what their wishes are because I need to carry out what they want. And if they're in their right mind and they're able to communicate with me, yes. Now, I'm not going to go in there when my patient can't breathe and he's purple and all that kind of stuff. Hey, you want a DNR? No, not going to do that. I want to talk to him and tell him. But the one thing I can tell you, if I can't tell you anything else about a DNR status, DNR does not mean do not care. Just because your patient has a DNR does not mean that I'm not going to provide him with the best care he can have. I am still going to do everything I can to make that person comfortable, and I expect you to do the same. Okay? I don't like that. It seems like so many times, and I don't know if it's just the floor that I'm on, that is one of the first things they report to me is that they're a DNR. And I think that gives the idea to some people, oh, they're a DNR, I don't have to do anything with them. That is not the truth. I'm going to take care of that DNR patient just like I would take care of anybody else. It's just when he gets into problems and can't breathe, I'm not going to pound on his chest. So please do not. You're going to see a lot of patients with COPD that have a DNR status. Make it just as comfortable for them as if we were going to pound and push meds. Okay? Let's see where I'm at. How far? How good am I doing? Here's my little COPDer. Oh, that's another thing that's real different with a COPDer is look how he is sitting with his O2 tank and a cigarette. Told you it's hard to let them boogers go. Okay? But look and see how, and we talked about this a while ago as far as making sure that the patient's body is upright and that we're stretching everything out. With a COPD, this is how they want to sit. they want to put a bedside table in front of them, and they want to lean over like this. Because if you can see that through here, right here, this area right here is stretched out, right? It's sort of stretched out, so it's giving them better expansion of their lungs, and everything's not pushing up on their diaphragm. I have seen patients dying that's how they wanted to sit. And there would be family members standing in front of them holding their heads up. Because this way is the way they're going to be able to breathe better. My brother-in-law had my mother-in-law sitting on the side of the bed yesterday, blue as could be. I'm thinking, okay. But they want, people who are having trouble breathing, they want to, no, she didn't know she was sitting up. But they want to make sure that they can expand everything using the least amount of energy. You know, if I ask a patient to do this right here, a COPD, he's going to start holding his breath, and then we're getting bigger problems. But if he leans over, the same type of expansion is happening if he would have been like this, and he can handle it better. So he likes to lean over that little thing like that. All right. Pneumonia, I don't know that there's a big difference in any other of the, I mean, I talked about the pathophysiology there. One of the biggest things that you will see, or maybe you tell me, all of the patients that you saw in the hospital that were getting ready to be discharged, and they were over 65, what was an order on there before they got discharged? Pneumonia or and the flu. How often can you give the pneumonia?
Once every 3 years.
5 years. Pneumonia's every 5 years. My patients that are at risk, like the COPDers, you can give it up to 3 years. The bad thing is, most of these patients don't write down when they had it last. So we don't know if they've even if they had it 2 weeks ago or what. So if you are in the situation that you are giving that pneumonia shot to the patient, since it's a 5-year duration, please give them a card and tell them to stick it in their wallet to keep with them when they come back and forth, because patients who have COPD are back and forth, and every time they come into the hospital, when they discharge, they're going to want to give them the pneumonia shot. So we got to have proof that they've already had it. I'm just going right along. We talked about pneumonia. We hadn't really talked about pneumonia. With pneumonia, the flu, and RSV, using my notes will be your best bet. It's not much reading, but you can use my notes. It'll be the best bet. There's RSV. Does anybody have any questions about those things? I know y'all have read them all. I told you don't leave me. All right.